Good afternoon, everybody. I hope you had good lunch, and now you're not going to sleep, but to be wake up and listen to the next speakers. Now, our next presenter is Dr. Sonia. Dr. Sonia is known, very well known everywhere. She worked in almost all the hospitals, big hospitals in the Emirates. You started with Sheikh Khalifa, right? Sheikh Khalifa, and then Tawam, and then
Mediclinic too.
So she's well known to everybody, and she's a lovely person and lovely presenter. Okay, Dr. Sonia.
Okay, Bismillahirrahmanirrahim. Thank you for this nice introduction, and thank you for the EOS organizer. Thank you for Dr. Ahmed, Dr. Aida, and Dr. Al Khair to give us always opportunity to share the recent data and together. So my talk will be about multi-factor analysis for pathology complete response in a chemotherapy-free regimen. And this is the beauty of the study. It's a phase 2 study, and in fact, it's about only use of immunotherapy, durvalumab and trastuzumab and pertuzumab in HER2-enriched early breast cancer. So this is my disclosure. And if you see here, this is a single-arm phase 2 study, chemotherapy-free regimen, durvalumab with the immunotherapy paired to trastu. It's called the DTP regimen, patients with HER2 plus early breast cancer. So the design of the study is made as patients more than 18 years, women, hormone receptor negative, HER2 positive, or HER2 enriched, stage 1 to 3 breast cancer, and the primary tumor should be more than 1 centimeter in the criteria, and nodal status also, any nodal status was accepted. It's a small cohort, like the number of the patients is only 39, but it's an interesting study because we are talking here about patients-free chemotherapy regimen. The regimen is including, as I mentioned before, durvalumab, trastuzumab, and pertuzumab over 6 cycles in the neoadjuvant setting without any chemotherapy. And the responders, we have 2 groups. The responders patients will go for surgery, then they will have a complete 1-year DTP for RCB01, and the patients who are non-responder, they will complete with chemotherapy as per physician choice, if you can see here, salvage chemotherapy in the neoadjuvant setting, and this is by physician choice. And then they will complete 1 year for a standard of care adjuvant HER2 therapy. Here, the primary endpoint, as you see, was the pathological response rate. Secondary endpoint was the pathological response rate on the PD-L1 positive population versus PD-L1 less than 1%, until the stages whether less than 5% or more than 5%, and 3 years disease-free survival with the safety data, which is very important. If you see here the response rate in all patients that were evaluated, although we see that it's a number of 37, but still is phase 2 study, but interesting because in the DTP regimen, you can see the pathological response rate achieved 67.6% comparing to 48.6% for the standard of care. And you can see that the smaller tumor size here, we have comparison, and we have actually study that is involving the T size, the stage, the TILs, and the PD-L1 stages. If we talk about the stage, you can see on the second row that whether you have a stage 1, the response with DTP will go up to 85% for complete pathological response, which is a very interesting number, up to 18% eventually for stage 3. If we go by T, this is the T size for the tumors that are smaller size, although in the criteria they have to be more than 1 centimeter, will have a complete response by 90%, and eventually the T3 will have 37%, but in the criteria, the T4 disease were having 0%. For the TILs, and we have been talking a lot in this morning about molecular and TILs, PD-L1, so the patient who had TILs less than 1 will have a 31% response comparing to the high TILs, which is expected actually, they will have 73%. The PD-L1 score also is very important as it emphasizes that If you have a CPS score that is low, you're going to have 2% of response pathologically, but as much as you go with a high CPS score, more than 10%, you're going to have 80% of responder for the population that were in the trial. Now, if you can see the correlation with the HER2-DX signatures that was already discussed in the morning by Dr. Arif, by the colleagues in the morning, you can see that for the luminal differentiation signature, you have a very good response with the predicting with the p-value of 0.017, and for the proliferation signature also you can see how much is also compatible with the study. Now, the HER2 amplification signature did not show eventually such response, but the model PCR score also showed that it's still correlating with the population who have model PCR score positive with the p-value of 0.043. Now, if we go to the DTP cohort mapping, and this is something related to really deep study with the mesenchymal and with the single cell sequencing study, the details that are insights into individual cell and their gene expression profile at both single cell patient and bulk cohort levels in this number, you can see that in these cells and in this patient's population that is 37, we have a total of 496,253 cells. From these cells, 158.834 represent epithelial tumor cells, okay? And 128,927 stromal cells, and 208 were immune cells. That is the biggest number. And if you can see on the right side, the DTP cohort actually, it's representing how is the tumor signature for the cohort. Now, if we go with this nice schema, you can see on the right side that the myeloid the myeloid cells actually and the immune cells distribution for this population, which is 208, was the most important that have been showing a response. And you can see here that the RNA sequencing identifies elevated myeloid cells in non-responder comparing to responder in the baseline study. In that picture, you can see also the plasma cells and the B cells. And in the baseline, the myeloid cells presence showed that there was less responder comparing to other stages. Now, if we have also this resistance patients baseline who are having higher pro-inflammatory SPP1 and macrophage, the myeloid subset in the mapping showed actually that there was, in fact, a responder with baseline and with the EOT, and non-responder also that you can see in the myeloid cells. So, in fact, the myeloid subset map showed that this population are the less responder. Now, if we compare to the population who had SPP1 from the time associated with chemotherapy resistant and worse clinical outcomes, this is a very nice study. I know it's deep. It looks like very emphasized, but this is really the beauty of things. Like we can prevent with this, which are the populations that are going to be resistant. So with that, in conclusion, the DTP trial with immunotherapy in neoadjuvant setting for HER2-enriched population, avoiding chemotherapy showed that in the HER2-enriched breast cancer, de-escalating with durvalumab, trastuzumab, and pertuzumab was well tolerated and achieved high response rate with 49% and partial response rate with the 68%, and several clinical and pathological parameters have been correlated with pathological complete response. As I mentioned, the smaller size, the staging of the tumor, the PD-L1 status was very important when we have high PD-L1, and the TILs also are contributing to give us a heads up who are the patients who are going to be somehow more responder for the DTP trial or the DTP regimen. In the molecular analysis, the following factors were correlated with the pathological complete response, the HER2-DX as signatures as I showed you before, and luminal differentiation, proliferation, and the model PCR that was shown in the signature cells. The larger population of B cells and plasma cells also was a factor for determining the response and the bad response, and the lower population of SPP1 plus STAM. With that, I finish my presentation, and thank you very much.
Thanks, Dr. Sonia, for the very nice presentation. Any questions to Dr. Sonia before we proceed with the next?
If she wants.
After each session, okay.
So just one comment. I guess, is this going to be ready to be implemented, or what's your projection on basically avoiding chemotherapy in some of these patients? Obviously, we had seen excellent data with chemoimmunotherapy or chemotherapy plus anti-HER2 in this case.
Correct.
It looks like adding durvalumab in this case had some value, but I mean, is this definitive, or this is obviously not a randomized trial, but do you see that proceeding anywhere in the future?
Thank you very much. I was expecting this question actually, mainly from Khair, but it came from you. Yeah, interesting question.
I cover everything, doesn't it?
Yeah. Interesting. In fact, yeah, it's actually avoiding chemotherapy is always nice for our population, and we know that a lot of patients eventually, when we talk about chemotherapy, they will be very reluctant, and many of them, we spend a long time in the clinic to convince them for having complete, here we are talking about complete and partial pathological response. I agree with you that the number of patients is small, is a cohort of 37 patients. It is still phase 2 trial. I know that someone will tell me, toxicity, financial toxicity. Dr. Benini, always he talk about financial toxicity between Durva, Trastu. But here we are talking also about quality of life, about admissions, about also patients who are going to be having sepsis, admissions from the chemotherapy, complications. It is a nice data, in fact. And if you see, not everyone will have the response as is expected, with the 68% for complete response and 48% for partial response. But if we have the criteria to be able to do the signatures for certain kind of population, the small tumor size, the staging, the TILs, the PD-L1, if we have these factors that are unified and we can give this chance for the patients, I will go for it.
Right, you have to choose, I think, the right patient that's appropriate sentence. Of course, we have more stuff coming. For the TILs, we don't know where to draw the line. This was drawn at 30%, some do 10%. So we really don't know. I think this is a new field for us. But these studies need to be done so we can choose who's the right patient for the right treatment to de-escalate the chemotherapy.
Let's do it in Gulf country then for our population, if we can do it, because it's phase 2 study, and I think it's really interesting to...
something called immunoscores recently, where it combined PD-L1 with TMB, with something else, with TILs, and you come up with a score, so that may be for the future.
And this is the molecular era, where we are like really in advanced stages. Thank you very much.
Thank you, Dr. Sonia. Thanks a lot.
Thank you.
Thank you.
Thank you very much. Thank you.
So I'll be delighted to present my colleague, Dr. Hassan Shahrayar, who is American board certified, a consultant, medical and hematologic consultant at Sheikh Shakhbout Medical City. He's going to talk about also quite a new trial, a palbociclib and hormonal therapy versus paclitaxel in combination with trastuzumab and pertuzumab as neoadjuvant treatment for hormonal receptor positive, HER2 positive early breast cancer. The floor is yours.
Thank you, Dr. Dina, and thanks to Dr. Aida and EOS for having me today as a speaker. So this is another de-escalation strategy trial. We all are excited about de-escalation strategies, but ultimately, as we know, that we need a level 1 data to change our practice. So in that regard, I think this was an interesting phase 2 study called the TOUCH trial, and these are the primary results presented by Dr. Luca Mellorni from Italy. So this is looking at palbociclib plus letrozole versus weekly paclitaxel, both in combination with trastuzumab and pertuzumab as a neoadjuvant treatment for patients with hormone-positive, HER2-positive early breast cancer. Okay, so just as a way of background, so we know that triple-positive breast cancer has a lower response rate in terms of PAT-CR and uncertain response to endocrine therapy compared to the other subtypes. So this is an area of unmet need. And also, we have preclinical and clinical data suggesting that adding CDK4/6 inhibitors to endocrine therapy and the anti-HER2 agents in this hormone-positive, HER2-positive breast cancer might be a potential strategy for chemotherapy de-escalation. But the challenge is that we don't have the biomarkers to select the right group of patients. So I think one of the key scientific part of this study was the using this gene expression signature called as RB-SIG. This basically composed of genes which were looking at the functional loss of RB1 and some of the other associated genes like ET, E2, F1, and 2. Don't ask me the full mechanisms of these genes, but these signature has basically shown that if you have a high expression, and there was an arbitrary cutoff to define high and low, if you have a high cutoff for RB signature, then you had more resistance to CDK4/6 inhibitors, and you are more sensitive to chemotherapy with the standard anti-HER2 agent. So this seemed like a nice biomarker to test for interaction. So they hypothesized that this RB6 status will show an interaction, and they randomized patients to these two arms shown here. So the inclusion criteria included postmenopausal women, hormone-positive, HER2-positive, and these were like early-stage tumors, so tumor more than 1 centimeter, but node-negative to N1 disease only. I'll show you in the baseline characteristics that majority of these patients were older with node-negative disease. They're stratified by the age and the nodal involvement. So they randomized 1-to-1 to the standard of care arm of paclitaxel given for 4 cycles in a weekly basis, 80 milligram per meter squared with the trastuzumab and pertuzumab, compared to the experimental arm of palbociclib plus letrozole for 4 cycles with the HP. So a total of 16 weeks of neoadjuvant therapy and then surgery. And the primary objective of this study was the interaction between the PAT-CR and the RB6 status. So it is not just looking at the efficacy difference, but actually looking at that interaction that they had predicted. So here on this lower right-hand side, they have shown their hypotheses and assumptions. So they were predicting that in the RB6 high group, they should see at least 50% PAT-CR rate in the chemotherapy arm and a 10% PAT-CR in the CDK4/6 arm. And the converse was true for the RB6 low signature. So this was the math that they came up with. So they randomized about 150 patients, and in the final analysis, I think about 60 patients were randomized to each arm. These are the baseline characteristics. So as I said, average age is about 69 years. And of these, mostly 2/3 of the patients were more than 65 years. The tumor size average was 2.5 centimeter, and 73% of the patients were node negative, so really early stage, low volume disease. Okay, and so this was the treatment administration schedule. So most of the patients on the palbociclib arm completed their 4 cycles, so 94% compared to 80% on the chemotherapy arm, so slightly, I would say, better tolerance with the CDK4/6. And sorry, the early discontinuation rate was also lower in the CDK4/6, about 3% versus 16% in the chemotherapy arm. So this is the efficacy data, PAT-CR rate, according to the treatment arm. So interestingly, both groups had a similar PAT-CR rate of about 33%, and overall PAT-CR rate was 33%. But here is the primary objective, which was to look at this interaction between the RB-SIG status and the PAT-CR. And interestingly, there was no correlation as they were hypothesizing, so it did not support the outcome. So in the RB-SIG high group, actually CDK4/6 did a little better compared to the paclitaxel arm, and in the RB-SIG low group, the CDK4/6 did worse than the chemotherapy. So it was hypothesized the opposite way, but the results came out the other way. So in conclusion, this is a first trial randomizing postmenopausal patients with hormone-positive, HER2-positive early breast cancer to receive this dual HER2 blockade in combination with either a de-escalated chemo-free backbone of palbociclib plus letrozole or the standard weekly paclitaxel. And the primary hypothesis that this RB-SIG status could predict a differential benefit of the two treatment arms was not supported by the study data. And they are doing additional translational studies, and I think that's where we need to wait more data, that the additional translation studies might reveal what led to the different outcome than expected. But interestingly, and I think even though it's a negative trial, there is a lot to learn from this study. The PAT-CR rate was about 30% in the CDK4/6 and the chemotherapy arm, and I think this is worth exploring in some other trial or maybe in a bigger trial with correlative studies. And also importantly, we saw that there was a better compliance with the CDK4/6 arm in terms of completion of therapy and the discontinuation rates compared to the chemotherapy. So this certainly supports further investigation. So with that, I would conclude. If there's any questions, I'm happy to take.
So I have one question, Dr. Shafir. Interestingly, that we have this combination and the CDK4/6 inhibitors with the anti-HER2. Yes, there should be a time for everything, and there should be the first trial. But what is really interesting that they use this combination and deprive these patients from the chemotherapy in a neoadjuvant setting, while we don't have any data for a combination of a CDK4/6, a positive data, with the anti-HER2, even in a metastatic setting. So we know quite well when the CDK4/6 started, it started like in the metastatic, then in the, we have an approval in the adjuvant, and so on. But to push it with the anti-HER2 in a neoadjuvant, although the primary endpoint was not, for example, a PCR, and this was RIPE-SING score and status, but this was quite strange for me.
I'm not sure when was the initiation of the study, like in terms of the other data we have from CDK4/6, so when was the enrollment done? But I think because they're looking at the older population, so I guess they gravitated towards palbociclib as the CDK4/6 of choice. But it's an interesting thought here that they wanted to move into the new adjuvant setting.
Just one point. Do you know if they looked at other markers? I didn't see it, like Ki-67 or...
Right, they didn't report all the data in the presentation, but there was a question about different subtypes, how they were responding to the CDK4/6. So the author commented that the HER2-enriched types had the better PAT-CR compared to the luminal types.
Right,
which would be
usually correlate with the Ki-67. Normally, right, those are the one we don't see a high PCR with chemo plus anti-HER2. We do have now the PATINA trial in the metastatic setting. That's now just came from San Antonio, which has a huge benefit when you are adding palbociclib also in the maintenance setting, at least, after chemo.
Okay. Any more questions?
Yes, Dr. Ryan.
patient with subsequent lines of therapy, when they exhaust like many lines of therapy, I used to combine actually CDK4/6 inhibitor with Herceptin because I felt like some of them, the hormone receptor status has a good drive to the disease progression. And I think this and the patina data just makes me more comfortable doing that in the metastatic setting as well.
Right. No, definitely there is a biological and clinical rationale. The only thing is, can we prove de-escalation works better compared to this strategy? I think so. This was looking at success of a de-escalation. I think it's about patient selection probably. We need more translational data to see.
Okay, next in this session, I want to present my colleague and dear friend, Dr. Hussam Marashi, consultant medical oncology at Tawam Hospital. He's going to talk about retrospective data of GLP-1 receptor agonists in breast cancer survivors, about weight loss and patient outcomes.
Thank you so much. Good afternoon, everyone. I hope it's time to wake up and enjoy the next session. This is the most impressive survival difference you're going to see. You don't need to be a surgeon, radiotherapist, medical oncologist to admire the data there. I have to say, San Antonio this year was really special, and special thanks to the scientific committee for choosing this particular subject for me. So, from the title, it's all about trying to lose weight in breast cancer patients, so about survivorship and how important the weight loss. I think this is one of the most common questions in our clinic once we finish adjuvant treatment is what we're going to do next. And I think this addressed very important question. The data comes from the MD Anderson. It's a retrospective study by Dr. Sukumar. And obesity is a big problem. I think whether we have a breast cancer or not, this is a big problem in our area. GLP-1RA is now more and more used in different indications. I know the number one reason used here in my observation is weight loss, but the drug is licensed for diabetes as well, type 2 diabetes. And we get asked this question from breast cancer all the time. Can I use it? Can we not? And the retrospective study here evaluated what happens if for those patients who use these drugs for weight loss and how it affected the outcomes, particularly for the patient attending the MD Anderson. When you look at the data, you see this drug has been used there for a long time. I thought these drugs are new to us, but you will see what I mean later on. So they have a big cohort of patients. They can look at their database, the MD Anderson, identify those who have a breast cancer. They also can look at their pharmacy records and see who has been prescribed on the 2 drugs available, whether that is what we call the Manjaro or the Ozempic, and they create a database. I know they included DCIS, but at one point they decided to exclude it out from their analysis. And when you identify a retrospective patient who's used these drugs, you need to match it with someone very similar, someone who has similar risk factors in terms of weight, type 2 diabetes, age, all other factors, so you can have a meaningful comparison. And to try to consolidate this data, make sure it's meaningful, they did 1 to 2, the one who had the drug of interest, and 2, they did not have received the drug according to their database. And they're able to generate Kaplan-Meier for overall survival and disease-free survival. So this is where we're going to forget for a minute that I'm a medical oncologist and just focus on people's survival. So in total, they have almost 1,000, more than 1,000 patients who met the criteria. And they looked at median follow-up for 4.5 years. But if you look at this, if you see here, 30 years, is that someone been on the drug for 30 years? So this drug has been in use, I guess someone who had diabetes for a long time. And the median duration of the use was 1.2 years. So what means people used it in the past, long time ago, and now they're coming to the database and able to look after a good number of years what happened to them. And 88% they used it after finished definitive treatment for the breast cancer, which means some of these patients we're going to talk about, they were having the treatment during the definitive breast cancer treatment. And the median time from breast cancer diagnosis to the initiation was about 4.4 years, and that ranged between 0 to 34 years. So it's quite amazing that the use of this drug is irrelevant to the timing of the breast cancer. And the data start to come here. So the median BMI was 33. So if you look at the median, these patients by definition were obese already. And some of them BMI 20 to 56. I believe any patient who loses weight in BMI 56 will have survival benefit regardless of any study. I know this, but that's the group of the patient. And if you look at those who median weight 86 kilograms and BMI, as I said, 33. If you look at those in patient, which they identify 389 patients who have invasive breast cancer who have the drug, the Manjaro or the Ozempic, approved for weight loss, the amount of how much they lost over a year and a half is not much. So 6 months, they lose only 2% of their weight. To me, that could be my meal, but that's not a lot for 6 months. For the 3 months, for the 6 months, 2.9. For the 12 months was 3.1%. So the amount of weight loss is not really significant, particularly if you think about that lady with a BMI of 56. They've done the analysis, so when they compare it, as I said, with those who have been on the drug and compared it to those who did not have the drug, they look at the patient who have the endocrine treatment. And I think that we all agree that these patients, unfortunately, will gain weight eventually after starting on the endocrine treatment. So if you look at what's been put in bold, so the 12 months change in weight was significantly associated with endocrine treatment. So once patient on tamoxifen or aromatase inhibitor, they do gain weight after 12 months. That's, we know this. And patients who receive endocrine treatment therapy experience on average 2.36 weight gain at 12 months. I think that's unbelievable. I think that's really good, because my experience, our patient maybe will gain more weight than 2.36 weight, finishing chemotherapy, the emotional stress, the endocrine treatment. So I thought that was really good for MD Anderson population. So they managed now to get 897 patients with invasive cancer who received the drug compared to with the control. And the DFS, so the disease-free survival, it does nothing for the breast cancer recurrence, yes or no. So they followed the patient for almost now 27 years, and they concluded that DFS, it's not significant. So it doesn't do much on the breast itself, but look at the bottom line. I thought that was very impressive. So the median overall survival was not reached for those who have the drug compared to someone who didn't get the drugs to lose the weight, and is 24 years. And the graph will talk in wonders. And that's the patient characteristics. There's nothing really significant. I thought from presentation that maybe the DCIS were not included, but they included in the whole group. So I don't know if that was included in the overall analysis or not. So that maybe something will be explained in the paper. And if you look at those who have triple negative, it's only 14%. So maybe the endocrine treatment for this patient didn't change much. And this is how much in median weight loss in 3, 6, and 12 months. So really how we look at this is look at the line 0 and see how much damage has drifted. And as I said, it's not big significant. But then this is the graph I think everyone just said, wow. Because on the left, the disease, what we call the survival hasn't changed, but look at the right, see the survival probability. It has massively separated, and that's from the minute they said go. So the minute someone starts, they separate very, very, very well. Of course, they concluded that this is the largest study describing real-world pattern. I couldn't see any big study than this. True, in my Google search, the medication was associated with really modest weight loss and possibly suggesting that patient finishing the chemotherapy, the metabolism completely changes, the endocrine completely have some resistance to this drug, but doesn't matter. There is an improved all-cause survival was observed despite not doing anything to the cancer. So the message is very strong here. And they have to conclude that more clinical trials are needed to investigate the role of these agents for weight loss. And it's very important to look at our patient survivor, and further exploration of potential anti-cancer biological effects for breast cancer reduction and cancer control may be warranted. Maybe it will be some IV Manjaro from on or something. And on that, I'll just finish.
Thank you. How do you explain that having no event-free survival, but there is overall survival? So this tells us that it's the effect on diabetes, on heart, which we can see even in patients without cancer.
I always see that's maybe also a limitation to the retrospective study, because there is unintentional bias. They went and looked for a patient who motivated to lose the weight, who's been on the treatment, who sought help. Those people were looking for help and they're motivated. So possibly their outcome might be better than those who said, I'm not going to be bothered, I'm not going to try to use it. So maybe there is effect to that. But how do I explain? I think that we all know that the chemotherapy does something bad to our patient metabolism, and whether that is anthracyclines, whether that is the syndrome X, whether that is the diabetes on the top of that. So I think that comprehends the data we have about the resistant exercise data that's been presented as well, that showed that resistant exercise have overall survival as well. So I think it's all one package. I think it's only one message, is that these patients' battle is not finished by the time they finish their different treatment, the adjuvant treatment, the 3 years of adjuvant CDK or the 2 years. The battle is what happens later.
Absolutely. No, I agree with Dr. Al-Khair comment and your comment as well. And my take-home message from this is that it makes it difficult to even lose weight on these medications, the patient's hormonal therapy. And this is something that when the patient comes to me and she wants to lose weight and she asks me about this medication, I think one thing we should say is that, yes, you can take it if there is no other contraindication, but at the same time, you should understand that maybe being on hormonal therapy, you might not get the best effect out of it. I think maybe this is like one, something that, it came to my mind. The other thing is that it seems that, as Dr. Al-Khair mentioned, is that overall there was an impact on overall survival, and that's probably because it's preventing maybe cardiac issues, a stroke, and maybe other outcomes. So maybe it's good for everyone.
As I said, I think when you put a range of BMI from 33, we have to agree that losing weight, regardless there is a cancer or not, will have to do something about overall survival. So this is a message for the community.
Maybe it's not only losing weight, because
and the differentiation between diabetes and
along the title, the molecular insight, perhaps there is an element of the metabolic cancerous cell affected by these drugs. So I don't know if there is biomarker studies looking at different adipose-related substances, increased, decreased, exactly.
There is more, I think those, I don't know, we've been a recent visit to the MD Anderson in Spain, and she have good data about some molecular, but this is very early stages. I think the message is clear, is these patients, with our help, they need to look after themselves, they need to control their sugar, they need to carry on, because they can make the difference.
One point I want to say, along the insulin growth factor, insulin resistance, we know that life or survival can be affected by insulin resistance, the degree of insulin resistance. So perhaps on that basis, you could explain the changes in survival. Although you would expect some changes in the DFS as well, because as you mentioned, we know exercise and weight control, those studies have been done for the last 10, 20 years. Shelbowski and others, they always have shown us that weight control or low-fat diet with exercise and pretty much weight control will lead to better, less recurrence, actually, by 25%. This is over 10,000 women study. So to me, I would try to put it in that context. However, it still doesn't explain why we didn't see any DFS difference. So I think there are so many variables, and like you said, retrospective studies, so you have to take it with a grain of salt in terms of forming big conclusions.
And there's another, even from the surgical point of view, I've been reading, there's also data on how PCR, the one I'm talking about, is even better for those who are underweight. So even, it seems to be, obesity does a lot of things for the cancer. So I think we should start thinking about referring more patients to the endocrine service. Everything. Yeah.
Having said that, we saw a lung cancer trial that it was better in obese patients, the survival.
Lung cancer is a different game of eating.
Thank you, Dr. Hassan. Just one comment. I was reading in a very interesting article also about the high sugar levels and glutamines also in cancer patients that is really interacting. Because when we give the medication, in fact, it's not only about weight, but about metabolism, how we control it. And we know that there is now also data that cancer cells can be fed by some kind of non-metabolized sugar. So this is all like together. Just a comment. Thank you.
I agree completely.
Thank you.
Stay away from. I'll do the. Okay, we'll come to the next speaker. A colleague and a friend for 25 years almost, a Tawam survivor for 25 years as well. He's a consultant medical oncologist at Tawam Hospital. He will be talking about circulating tumor DNA, CTD. We're digging even deeper now.
I don't know what you'll do.
Okay, you'll finish the...
Yeah.
Okay, Nouri, it's yours.
Thank you, Falah. Assalamu alaikum. Thank you, Falah, for the kind introduction. I don't know how deep we will go far in trying to find more surrogate or biological marker to try to define or to have to define more the risk of our patient to recur. And this is one of the studies that has been presented in San Antonio regarding circulating tumor DNA, ctDNA, and also another part of it, which is called dormant disseminated tumor cells. We know that for almost 20 years that have been studied regarding the bone marrow, the nest of bone marrow cells there, but we don't know really if this bone marrow nest have some impact in the recurrence or not. And this study has been done within the study called the Surmont study. It has been presented by Eleanor Taranto. It's a single institution. Okay, so we understand that recurrence in early stage breast cancer occurs about 30% of the patient, and we've been reviewing that since this morning. We got all the type of recurrence and all the risk that the patient can have, but we have to understand that one of the mechanisms of recurrence is reactivation of disseminated tumor cells. These disseminated tumor cells are the reason that patient has recurrence, either local or metastatic, and especially metastatic disease. But the presence of minimal residual disease, whether by dormant tumor cells or circulating tumor cells, increase recurrence risk. This is unclear which patient have dormant tumor cells, which patient will reactivate, and which will not reactivate. So we'll try to determine which patient will, if this cohort of patient will help us to determine or to understand which patient will recur or not. So the primary objective of the study is to evaluate the association and temporal relationship of ctDNA with dormant tumor cells in high-risk breast cancer survivors and the relationship of these biomarkers with recurrence. And we understand that this is what, so ctDNA from circulating and the bone marrow relation when these dormant tumor cells might become circulating cells and lead to metastatic disease. So the PenSurmont study is a single-center prospective longitudinal cohort study examining the minimal residual disease biomarkers among patients within 5 years of breast cancer diagnosis, so the first 5 years, and try to review the data. The eligibility are all high-risk patients with post-neoadjuvant treatment, not positive, triple negative, and who all completed definitive treatment for early breast cancer. The study procedures, we do a bone marrow aspirate to evaluate for dormant tumor cells and via immunochemistry. But we also do a ctDNA to assess the presence of the ctDNA by the bespoke radar assay. So we define then two populations, the dormant cell population, which is referred to the clinical trial, and the dormant tumor cells who remain in surveillance column here where we will repeat a bone marrow assessment and also ctDNA by blood collection. And this will be the main cohort of the patient. So if we see here, the main cohort initially was 184 patients. The tissue submitted 121, but the evaluated one successfully was 114, and out of them, plasma was submitted for only 130. Out of them, we have 109 patients who completed the whole assessment. That means the bone marrow and the ctDNA. And out of them, what's the result? We have 9 patients who had ctDNA positive and 100 patients with ctDNA negative. So if we take that, so 9 patients out of 100 represent 8% of patients where cumulative ctDNA was positive. For dormant cumulative disease positivity, it was 35%. That means 39 out of this 109 have these positive dormant cells. And the study will include all DTC dormant patients who went on trial. This is the patient characteristic. It's a really busy slide, but I want you to focus on the lower part of the bottom of this. And we see here that the local recurrence for patients who had ctDNA positive was 67%, while 33% for ctDNA negative. For metastatic disease, distant metastasis, 56 versus 42. And also patient alive, 5% only with the ctDNA positive, compared to 95 for ctDNA negative. And for patients who died, out of the 5 patients who died, almost 80% of them have ctDNA positive. So this is not new. That we know that ctDNA positive patients at initial who are at high risk of local recurrence and distant metastasis. So now the other part is this patient with dormant cells? So the patient who have mainly ctDNA negative, but they have dormant cell. These are the cohort of interest. And these patients are only actually 30 patients out of, we have 34 patients who are DTC positive. Out of them, 30 patients have not relapsed. So only 4 patients relapsed within the pool of patients who have these dormant cells. Only 4 patients recur. And out of these 4 who recur, 3 of them showed before that they have a ctDNA positive. And that's why we elaborate the hypothesis that we have to maybe found a way how to control, because doing also bone marrow on a yearly basis and ctDNA just to dig and to get these 3 patients out of 34 is also something that is not can be going to a daily practice. But from this, the median time also for that was 21 months, while we see that for patients with only ctDNA positive, it was 15.2 months between the time of the study and the relapse or appearance of the relapse. So in the conclusion, so dormant, the patient with dormant positive were identified who subsequently developed detectable ctDNA and clinical relapse. The main issue is, so this patient, how still only 3 patients out of 34, or 4 patients were, but only 3 were circulating tumor DNA. So the hypothesis behind it is, should we go further in clinical trials or to try to dig more to just pick up this patient who will recur within these 5 years with this criteria. I think this is still a futuristic approach, but definitely it's important to know that having this nest of patients is not yet a prime, and it's not a risk factor that we can consider. We know that a lot of patients have this nest in the bone marrow, but not all of them will go to a circulating cells and become metastatic disease later on. Thank you for your attention. I removed the microphone from Ghazal. No, I cannot hear you.
I believe you've mentioned it earlier, but what was the percentage of the patient who had DTC? The percentage?
The number. Was out of this 109 patients, 34 had the DTC positive.
Only 34.
30, yeah, only 34 patients.
Maybe I did not catch this from the presentation. The dormant cells were evaluated by doing a bone marrow biopsy?
Yeah, bone marrow aspirate, and they were followed by bone marrow aspirate and circulating. The aim of it is, we know that this patient have dormant cells, okay, but we don't know if this patient will really be, being positive will increase the risk of metastatic. What we knew now that is the patient who have positivity of ctDNA later on will have a worse prognosis and will have metastatic disease later on. So I think that the most important message remains that ctDNA is important, and this is so it's the easiest way because we see that most of the patients with ctDNA positive has recurred and they have a very poor prognosis.
I'm going to say one word.
Go ahead.
No, I think this is a baby step, but I think in breast cancer, unlike other cancer, the only cancer we see recurrence 20 years later. Mm-hmm. So I think this is where this is stemming from, because we always think there are these dormant cells somewhere, probably in the bone marrow, you could find them. But something happened to the patient that triggers, going into the circulating part and then recurrence. So I think it's fascinating how these cells survive in harmony in the bone marrow without being seen. That's always fascinating to me as well.
Okay, my first personal opinion, I mean, going and digging within the bone marrow to look for these dormant cells, for me, is useless. First of all, because we see that the number of patients who really goes to a circulating is very limited. And second thing, even a negative patient, even patient with CT or with dormant cells negative, you cannot show, because when you take a biopsy or whatever you take is a limited portion of it. So that's really...
It's a baby step.
So you will never be sure. So I think the best way remain is circulating tumor cells, CTC and ctDNA are better approach, easier, less invasive, and giving a really very good predictive value. And I have to say that it's an honor, a pleasure to have this from Dr. Falah, who is my mentor, who is my friend, and our senior oncologist.
You are same age, no?
والله يقرأ أفكاري.
Now we come to a person that I would like to keep on the other side, not here. because he generates all the questions and so on. But I think for once to put you on the podium so we raise your adrenaline expecting some questions. Dr. Hassan Ghazal is an American board consultant medical oncologist at King's Hospital, a good colleague, a wealth of knowledge, a lot of questions. Mr. Hassan of Dubai rather than Vogel of New York.
Hassan Dubai.
Thank you.
Dr. Hassan.
Thank you. Okay, thank you all. There's still a lot of people in the room, so thank you. Dr. Nuhad is here, so he came just for my talk. Anyway, I was chatting with Nuhad that every San Antonio, we have to hear Nick Turner. We always hear Nick Turner from UK, presenting something about ctDNA. So again, these are, I would call it baby steps to try to clarify a complicated subject, but it's always nice to see attempt to explain the ctDNA story. So this is the so-called ZEST trial, which is basically ctDNA surveillance. It's a randomized phase 3, but as you will see at the end of the day, it was really poorly executed because of the poor accrual, and then we end up with very small numbers to make big conclusions, unfortunately. So a lot of things invested, you can see how many authors here, but it's unfortunate at the end that the bigger conclusion is not what they were hoping for from the start. This is basically to look at the effect of niraparib in this case, so not just looking at ctDNA, but whether niraparib given versus placebo in the triple negative, and there were a few HR positive as well, but majorly triple negative, HER2 negative BRCA mutated breast cancer who had molecular residual disease after definitive therapy. So the concept here is to look at ctDNA in a way clearance with the use of niraparib. So here is Nick Turner. So the background is that a lot of these patients, as we've been hearing, do have recurrence up to 30%, especially in the triple negative. And there is no standard MRD test as we have in hematologic malignancies, for example, where the concept of MRD started. In breast cancer, we're still taking baby steps, I think, or even in solid tumors in general. So this is, they use the ctDNA to look for residual disease after completion of so-called definitive therapy or standard therapy. And then in these cases, this is where niraparib was introduced as a, obviously, PARP inhibitor, which is approved in ovarian cancer. And they tried to here jump into the breast cancer field. And again, 2/3 almost of these triple negative may have HRD, not just BRCA mutation, but some form of HRD deficiency repair. So this is the phase 3 trial, a ZEST trial, double-blinded, MRD-directed, to assess whether the introduction of niraparib will improve the DFS in patients who completed their treatment and had the positive ctDNA, obviously without evidence of radiographic progression. So as you can see, we have two cohorts. We have the BRCA mutated patients, which included some HR positive and triple negative, and the randomization to niraparib versus placebo. And the initial endpoint was obviously looking at DFS and secondary endpoint as OS. And the cohort 2 was a wild type BRCA triple negative, and this was a 600 patients, the majority of patients. And they were doing serial ctDNA testing to monitor for MRD. Again, these were stage 1 to 3 breast cancer. They included, obviously, all triple negative, regardless of the BRCA mutation or not. They had to have a completion of their standard therapy with curative intent, and the HR positive were allowed adjuvant endocrine therapy. So they are all getting the standard therapy. Also, some of these patients had neoadjuvant chemotherapy, and if the tumor did not respond, obviously they excluded those. So at the bottom here, we start to see the first pitfall, that although DFS was the primary endpoint, it was changed afterwards to just safety and tolerability of niraparib because of the enrollment trouble. But they were looking at recurrence-free interval. So obviously, Signatera here was the main assay used in this trial. And again, this was based on the whole exome sequencing of tumor tissue. As you know, Signatera used NGS on the tissue, and they tried to match in the blood samples afterwards. So it was tracking 16 mutations per patient, and it was done every 2 to 3 months, which is what we normally would recommend now, even off study. So again, 200 randomized patients, cohort 1, and 600 cohort 2. Cohort 2 is the purely triple negative type. And again, the power to find the statistical analysis, 90% power for testing the primary endpoint of DFS at one-sided level, 0.025 on the alpha level. The study was terminated with 1,900 patients recruited into ctDNA surveillance, and there were 40 randomized. So you can see we started with a pre-screening 2,700 who entered ctDNA surveillance, 1,900. Then who were ctDNA positive, we dropped to 147, and who entered screening was 96, and who were randomized were down to 18 and 22. So you look, we started with 2,700, we ended up with 18 and 22 that actually were randomized to answer the question, what's niraparib is doing to these patients. So there were various reasons, obviously, for each step, the decrease in the number, but mainly because the ctDNA positive group is going to be so low, and that's why they needed nearly 3,000 patients to end up with only 40 patients to be randomized. And you can see 4 patients had recurrence despite ctDNA negative. So again, it's not 100% safety, even if you have ctDNA negative. And you can see 8% of those who were ctDNA positive, and of those 50% had radiologic recurrence if you are ctDNA positive. Characteristic of the patient population, you can see age group 50 or below 50 or above 50, almost the same, and obviously majority are women. We can see various representation, obviously the Caucasian 80%. We have a few Asian, mostly white race, triple negative 88% and HR positive 11%. The BRCA mutation was present in 22% and wild type in 36%, and yet 40% unknown. Node positive was about a third of patients and negative 60%. You can see the stage 1, 2 versus 3. Good distribution, 25, 40, and 30% between 1, 2, and 3. You can see the pathologic CR was in 34% versus 65, none. No pathologic CR. You can see neoadjuvant in a third of patient, adjuvant in a third, and both in another third. So really mixed bag. And you can see here endocrine therapy was limited here because the number of HR positive patients were low. So ctDNA detection, you can see if you are triple negative, you have 1,600 out of 1,600 patients. The rate of ctDNA positivity was 8%. In the HR positive, again, small number, 200 patients, it was 5.5%. In the BRCA mutant population, 424 patients, the detection rate was 5%. In the wild type, 8%. So a little bit higher in the wild type than the mutant. If you look at node positive, that makes sense, near 12% versus node negative 5%. And the stage as well, you can see as you go from stage 1 to 3, you go from 2, 7, and 14%. Pathologic CR clearly has the lowest. ctDNA positive is only 2%, and the non-PCR was near 14%. Then systemic therapy versus no systemic therapy obviously depend on the risk of that patient. So there's some bias there who had systemic therapy versus not. Capecitabine, those who had capecitabine, still we see 13%, probably due to the higher, those are non-PCR patients who were given capecitabine, and that may explain the 14% ctDNA. Okay, timing of ctDNA detection from end of definitive treatment. The bottom line, the less than 3 months, so really after you finish treatment, when your ctDNA is around 7%, that's the highest. As you go 3 to 6 months, it dropped to 5, and then drop to less than 3% once you go beyond 6 months. So obviously, ctDNA is an early, in these cases, it's an early phenomena. You will catch it in less than 6 months from the end of treatment. So in triple negative, 60% ctDNA positive were detected less than 6 months from the end of treatment. HR positive, they couldn't draw a big conclusion because the number are small. One observation about the radiographic recurrence at ctDNA detection. Obviously, recurrence was associated with higher ctDNA level. So the higher your ctDNA level, the earlier your radiologic recurrence as well, which makes sense. Obviously, once you have more ctDNA, you have more cells there, and your risk of finding a recurrence will be higher. So again, characteristic of the randomized patient, not much different. And you can see the placebo versus randomized, the numbers are small, 18 versus 22. But in general, you see more mutant, 22% versus 5% between niraparib and placebo. And the rest are more or less equal. This is the bottom line on the recurrence-free interval, which is what they could make some conclusion, that obviously if you were exposed to niraparib versus placebo, your recurrence-free in month is 5.4 with placebo, 11.4 with niraparib. So obviously we are delaying the recurrence. However, you can see the curves join together. So you have this early separation, and then the curve converge, but the hazard ratio is 0.66. And when you look at median ctDNA level, again, as the ctDNA level goes up, you see the recurrence is earlier. So you have 3.2 months versus 5.7 months when your ctDNA is high. When your ctDNA is low, you can see 15.9 months with niraparib versus 7.4 with placebo. So again, the concept here is that introducing niraparib in this population certainly delayed the actual recurrence, but you know, it's hard to draw a big conclusion. The numbers are small, those who ended up being randomized like this. So we're making all these based on 20 patients, unfortunately, after starting with near 3,000. So this is the first phase 3 trial of MRD-guided therapy in breast cancer. It was terminated early because of low randomization rate, unfortunately, because this was a good concept to check. The other thing not mentioned here is how long did they receive? I could start searching how long they were receiving niraparib, and it wasn't mentioned clearly exactly. I think they were going after the main thing is the concept rather than like a randomization in a blinded fashion to really find out the value of niraparib on the long run, or how long would you give niraparib. As you know, in the adjuvant setting, we give 1 year of olaparib, so no real data on niraparib. So anyway, most frequently, we are going to catch the ctDNA within the first 3 months, 3 to 6 months after completing therapy. High rate of radiographic recurrence when you have especially high ctDNA versus low, so that matters as well. And it mattered in the number of months before you have the radiographic progression. So again, it was not powered to evaluate the effect of niraparib versus placebo given early termination, but the recurrence-free interval, as I showed you, is numerically better on those who received niraparib. So thank you. That's it.
Thank you, Dr. Hassan. I know that all of us, we want to take revenge from him, okay, and ask him like 100 questions, but because of the time, I will allow one question to start there.
Okay, go ahead.
Yeah.
For your population, for your patients, like if you have opportunity and it's
So not based on this study, but we have other studies looking at Signatera in particular. We mentioned earlier the Monarch trial where they saw correlation if you clear your ctDNA. So I think these are all I call baby steps towards, I don't think they are ready for prime time to change therapy based on ctDNA, especially after you finish all your standard therapy. But I think the only provocative thing from this was the separation between niraparib and placebo. But am I going to use it? No, of course not.
Those are like triple negative also, with high risk.
Yes,
Yeah.
yes, those were high risk.
So it's an encouraging study for me. I know it was not positive, but I will go for like thinking about same steps for triple negative breast cancer, especially those who have like residual disease, pathological residual disease or metaplastic tumors. Because
of course, they all continued whatever is standard these patients were getting. That's why you saw the capecitabine, you saw the pembrolizumab, so they were all getting the full standard therapy. This is an addition if your ctDNA is positive.
Last question there, yeah.
Yeah, it's not a question, it's just kind of a comment. I mean, well, it happens that I chaired the session at San Antonio where this case, when this study abstract was presented. We are running a regional study, if anybody interested. We're looking at patients with triple negative who achieve pathological CR. Then the question to continue or not to continue in adjuvant setting would be based on ctDNA. So if anybody has interest to join, I mean, this is something where you can use ctDNA in probably a wiser fashion.
Sitting, sorry, only with pembro or adjuvant sitting even if they are like PARP inhibitor?
No, he's talking about pembro continuation after
Talking about pembro, yes.
And this is an important question financially because, especially in our countries where it's expensive, do you really need to finish the 1 year of pembrolizumab? Hussam, maybe final comment.
So Dr. Kazari, always enjoy asking us the difficult question. Now we have CN track studies negative with circulating DNA. We have ZEST study completely negative. Where would that leave monitoring circulating DNA in the practice? I think it's just for clinical trials, isn't it?
Well, right now, that's why I said earlier that it's not ready for prime time, but I think the only good study was the Monarch trial that clearly showed those are the patients that benefited from the adjuvant abemaciclib. Yes?
Doctor just commented this and the untracked same story, negative, which tells you for high-risk triple negative breast cancer, your clinical follow-up, your clinical sense is still far better than the molecular tools. I am a big fan of the fancy molecular tools, but we are still like kids playing with those. And Monarchy detected, yes, it was useful for the hormone receptor positive breast cancer, population, which is actually a less pressing need. So we really need to be, at least in clinical practice, mindful of the cost and the benefit. There is no...
no, I agree. This is just proving that if you are ctDNA positive, you have much higher risk of recurrence, but what can you do about it is still up in the air.
No, you don't need even the ctDNA to tell you that you are...
No, of course.
Because most of the time, radiology detects that, your clinical sense detects that already far earlier than ctDNA. You need ctDNA to be preceding.
Of course, that's why we are paying for these expensive tests. It's $5,000 to tell you something about the risk of recurrence.
Thank you, Dr. Hassan.
So there are people asking you questions. You cannot just
So I have the privilege, all the privilege, to introduce a colleague and brother, head of department, and my boss, Dr. Said Hamad, leading the best oncology team worldwide, which is me. Dr. Said Hamad, consultant medical oncology, head of department, Dubai Hospital, and is going to talk about the impact of anthracyclines in high genomic risk, node-negative, hormonal positive, HER2-negative breast cancer.
Thank you very much, Dr. Dina, for kind words. And thank you, Dr. Aida, and the organizing committee for inviting me. So for the, I don't know, least scientific topic of the session, but let's have a look at it. You know, there are very few things in science which unite us, like gravity. But most things are like, it's a pineapple on a pizza. So some people love it, other people just say it's a crime. So let's see. When I was training, I was told anthracycline is the most important drug in breast cancer. That's what I was told. But then in 2016, things changed. But it looks like resurrection again. It's like a movie sequel when you think it's all over, and Terminator is back. So this was presented by Dr. Nan Chan. So we know the TERRAX study, which showed the benefit of chemotherapy in hormone-positive, HER2-negative breast cancer patients who had the high risk score more than 26. And this is a post-hoc analysis from this study, which shows the benefit of anthracycline on the addition of taxanes in patients with risk of more than 31. And it was limited to patients with a tumor size more than 2 centimeters. So let's have a look at it. It's quite interesting, the data. So we remember now going back 2016, ABC trial, 3 trials came close to each other, looking at patients with node-negative breast cancers, and they looked at TC versus ACT, and what this trial showed were they were more or less equal. So there was early termination of the studies because there was no additional benefit of anthracyclines for these group of patients. But obviously there were some questions with regards to high node-positive disease, especially more than 4 positive. So people still were using it for high node-positive disease. So in terms of the risk scores, the cutoff for 26 and 31 have been previously evaluated for the benefit of chemotherapy. So what they have done in the study, so they looked at the gene scores and divide them into these 3 big groups. So you have low risks, and you have the intermediate risk, and you have the high risk. And these are all patients who are HER2 negative, node negative patients, but high risk T1B included. So we exclude the patient. We exclude the patient which are low risk. So 0 to 10 risk scores, we exclude them. So we look at just the patients which are about 10,000 patients in mid-risk and the high risk. And then they looked at 2 chemotherapy regimens, so ACT and TC. And then you have patients in the experimental arm receiving endocrine therapy alone, and in the standard arms, you had the endocrine therapy plus chemotherapy. So altogether, we had around 2,500 patients which were included in this analysis, because there's some patients who did not receive ACT regimen in the study. So these are the patient characteristics. It's not a randomized data, so you will see bias here in terms of the patients which are in each group. So you see more high-risk patients probably in the TAC group as opposed to TC group, slightly higher tumor size, slightly less PR positive. Even when you look at the recurrence scores, slightly higher recurrence scores. So physicians are choosing really patients who are high risk, but there's still a bias in this baseline characteristics. So let's look at the, said all this. So these were the primary outcomes. On the left, you have the risk score less than 31, so no difference between ACT or TC. But when you have a risk score more than 31, you start to see this benefit in terms of distance recurrence-free interval, almost 5%, which is quite significant, with a hazard ratio 0.32. Let's look further in terms of survival outcomes in patient, which is a risk more than 31. So you have distance relapse-free survival against a significant benefit favoring ACT versus TC. And there is a trend towards overall survival in this analysis as well. When we look at the subgroups, the subgroup which shines really is the one which is size more than 2 centimeters. There's clearly a benefit these patients derive if you add anthracycline to the chemotherapy regimen. What about menopausal status? So premenopausal, so younger patients are driving benefit from the anthracyclines. Obviously, we do worry about long-term toxicity, but there is a clear benefit. Postmenopausal patients, we did not, it was not statistically significant. There's another interesting thing is with regards to what happens as the risk score increases. So it's exponential benefit in terms of, So it is an exponential benefit when the risk score increases. So if you see when you have, I think there's a slide missing, you should have something on the, okay, now better. So as your risk score increases, the benefit of anthracycline increases, as you would expect. So that is interesting as well. So if someone who has a risk score of 50, definitely they will drive a significant benefit for the addition of anthracyclines. What about alternative chemotherapy regimen? CMF should not be used, really. CMF is really looking very poorly here, and as well as the AC on its own is not as good. So TAC seems to be declining the risk of recurrence over time. So that's the message really from the study. So limitation obviously is a post-hoc analysis. It's not a randomized data. Chemotherapy choice was not randomized. People use TAC in high-risk patients. And obviously, we're all concerned about late effects of anthracyclines. So these were the conclusions of the authors. Then in patients who are high-risk, hormone-positive, HER2-negative, lymph node-negative patient with a risk score of more than 31, there was significant benefit in terms of distance relapse-free interval, 96% versus 91%, as well as a distance relapse-free survival in favor of TAC. There is trend towards overall survival, but obviously it was not statistically significant. The most benefit we saw was in patients with tumor size more than 2 centimeters. And as the risk score increases, greater than 31, it corresponds to increasing benefit from the addition of anthracyclines. So I think anthracyclines, in the present day, I was trying to work out, what should I call it? Is it Elon Musk controversial, or is it Taylor Swift, a comeback? Thank you very much. With anthracyclines all the way. Looks like everybody agrees, except Dr. Hassan.
So I think you have to take that, the score itself, by itself, is not enough. That's why they came up with the ClinSeq, if you know, as you well know. So if I have a 0.8 centimeter tumor with a oncotype 31, it's not like a 3CM with 3 positive node with the same score. That's why we came with ClinSeq. So if I have 0.8 tumor, Dr. Nuhad will agree with me, that's not the same risk or the same benefit from anthracycline.
Just 1 minute, but so if a tumor is 3 centimeters and they have 3 positive lymph nodes, why would we do a score even?
No, I'm just saying, I'm just comparing as an OncoScore to OncoScore. So to conclude that all OncoScore 31 will benefit the same from anthracycline, that's my comment only, that's not completely accurate.
Hassan, I'm usually very picky with generalizations, but he mentioned very nice analogy with Elon Musk and Taylor Swift. Anthracyclines do work. When you have something controversial and the bulk of evidence speaks that it does work, it means it works, because you can always find a trial to prove that something is different from what everybody else thinks. But actually last year, Dr. Nihad, the early breast cancer trialist group, right, at San Antonio, did do an overall, it's very interesting. The ABCTG went back and looked at their data, and even in that meta-analysis, there was definite benefit for anthracyclines in all high-risk groups, ER positive, triple negative, HER2 positive, contrary to what they told us like 5 or 6 years back, or when Dennis Lemon came up with the TCH regimen that you can forget about anthracyclines. So the fact that the meta-analysis confirmed the benefit, even in node-negative disease, it's coming back, it's telling you something, that anthracyclines are beneficial in breast cancer, period.
No, I'm not arguing that. I'm saying the degree of benefit may change, no question, but I agree with you. In another analysis, they said, well, the node-negative, there is numerical difference, but not statistically significant.
I don't care. It's clinically meaningful.
So that's my caution only.
And this is important.
Yes,
simply
let's hear from Dr. Nuhad.
Yes.
In my opinion, whenever you decide to give the patient chemotherapy, give the best that you have.
Yes, agree. Fully agree.
I would like you to voice your disagreement. Cutting angles just because the patient is young or does not want to lose hair or something like this is okay, but explain it to the patient.
I think we need to look at the data. Yeah, it's quite strong.
It's AC. Yeah, we already. Yes, the F has been.
Thank you. Thank you, Dr. Hamad. Another privilege to present Dr. Muhammad Farouk. Dr. Muhammad Farouk is a colleague and friend. He's leading the breast clinic and the breast MDT in Dubai Hospital, Consultant Medical Oncology, going to talk about updates from the Olympia trial.
Assalamu alaikum, good afternoon. Thank you, Dr. Dina, for the introduction, and thank you, Dr. Aida, for the invitation. So, my talk is update on Olympia trial. Olaparib in BRCA-mutated early breast cancer. So this is a pre-specified pooled analysis of invasive disease-free survival, DDFS, and overall survival 10 years from first patients in. Okay. So this is the rationale of the study. We already know inhibition of PARP on DNA results in loss of function of BRCA1, BRCA2, as well as the HRR, loss of function or pathogenic variation in the BRCA1 or 2 predisposes to both ER-positive and triple-negative breast cancer. So we already know from Olympia study results that olaparib significantly improved invasive disease-free survival, distant disease-free survival, as well as overall survival in patients with BRCA-mutated early breast cancer. So this is an updated analysis in terms of results of the third pre-specified analysis at 10 years from first patient in, an additional 2.6 years follow-up from the last update. So this is the trial schema. Germline mutated early breast cancer patients, ER-positive or triple-negative, stage 2 or stage 3 disease. Two groups of patients who received neoadjuvant chemotherapy, and if they have triple-negative breast cancer, they are required to have a residual disease post-chemotherapy. Patients who had ER-positive disease, they were required to have a CPS plus EG score of 3 or above to be eligible for this trial. Patients who had upfront surgery and they were in the adjuvant setting, if they had triple-negative disease, they had to have either T2 or N1 disease, or if they have hormone receptor positive HER2 negative disease, they are required to have N2 disease to be eligible for this study. So patients were randomized to 1-to-1 ratio to receive olaparib 300 milligram twice a day for 1 year versus placebo, and the primary endpoint was invasive disease-free survival, and the secondary endpoints were distant disease-free survival as well as overall survival. So these are the patient characteristics. Median age 42, as you would expect in BRCA-mutated breast cancer, mostly younger patients. 70% patient had BRCA1 mutation, 28% BRCA2, 62% patient were premenopausal, and these characteristics are very well balanced across both groups. Again, looking at the hormone receptor positivity, we all know that vast majority of patients, over 80%, were triple negative, and just under 20% patients had ER-positive HER2 negative disease. All patients received chemotherapy, 50% in the neoadjuvant setting and almost 50% in the adjuvant setting, and this is very well balanced between these two groups. This was the protocol planned analysis. We already know after data cutoff of March 2020 as well as July 2021, we have seen significant improvement in IDFS as well as DDFS and overall survival with addition of olaparib for 1 year as compared to placebo. So this third pre-planned analysis was conducted 10 years after first patient in. So these are the types of first invasive disease-free survival events. If you look at the number of IDFS events in both groups, 178 in the olaparib group versus 258 in the placebo group. And if you look at the type of recurrence, distant, regional, loco-regional, contralateral invasive breast cancer, as well as secondary primary non-breast malignancies, they are lower as compared with olaparib in the olaparib group as compared to the placebo group. This is the IDFS analysis in the overall population, and if you look at the 6 years IDFS, 79.6% versus 70.3%, a difference of 9.4% with a hazard ratio of 0.65. Again, this benefit was seen across various subgroups. This is IDFS analysis by hormone receptor status in the triple negative patients. The IDFS hazard ratio was 0.652 and it was 0.68 in hormone receptor positive HER2 negative group. So this is the distant disease-free survival in the overall population. At 6 years, 83.5 versus 75.7, a difference of 7.8% favoring olaparib with a hazard ratio of 0.65. Again, the distant disease-free survival was better across all subgroups favoring olaparib. So this is all deaths. In the overall population, total number of deaths were 107 in olaparib group versus 143 in the placebo group. And if you look at the primary causes of death, breast cancer recurrence, 94 deaths versus 128 deaths in the placebo. This is the overall survival data in the overall population at 6 years, 87.5 versus 83.2, a difference of 4.4% with 28% reduction in the risk of death favoring olaparib. Again, olaparib seems to work across all subgroups. So this is a summary of adverse events of special interest. Of note, if you look at the myelodysplastic syndrome and AML, it's very reassuring to see there is no increment in the adverse events related to these two side effects with olaparib. And if you look at the new primary malignancy, in the olaparib group, there was less number of new primary cancers as compared to the control group. Again, new primary malignancy, 26 patients had breast cancer in the olaparib versus 36 in the placebo, and 5 ovarian cancers as opposed to 14 in the placebo group. So this is again a summary of new breast and ovarian cancers during the follow-up. Almost 50% patients had bilateral mastectomy either before or after randomization, and this was similar across both groups. Patients with contralateral invasive breast cancer in the olaparib group was less in number, 34 as compared to 42. And similarly, if you look at the new primary ovarian or fallopian tube cancers, the numbers were low as compared to the placebo. So on study pregnancies and outcomes, 41 patients in both sides, number of pregnancies were 51. And if we look at the numbers in terms of full-term, premature births, spontaneous miscarriages, they are not really statistically significantly different as compared to the placebo. So this is the conclusion of the study. At 6.1 year median follow-up, 12 months of olaparib after neoadjuvant chemotherapy continues to demonstrate clinically meaningful improvement in invasive disease-free survival, distant disease-free survival, as well as overall survival in patients with germline BRCA mutation positive, high-risk HER2 negative breast cancer. Olaparib benefit was consistent across all key subgroups, including patients with high-risk ER positive disease or patients with triple negative cancer. There were fewer new primary malignancies in the olaparib arm. There were no new safety signals were observed with longer-term follow-up, and there is no evidence of increased risk of MDS or AML. So this data continues to support adjuvant olaparib as standard of care for patients with germline BRCA mutation positive, high-risk HER2 negative primary breast cancer, and therefore highlight the importance of germline BRCA mutation testing for treatment planning. Blinded follow-up for the final planned analysis continues until June 2029. Thank you.
I don't understand the slide for the pregnancy. Are these patients supposed to be postmenopausal or even induced postmenopausal by LHRH?
Sorry?
I don't understand the slide for the pregnancies. They have shown, aren't these patients at high risk and supposed to be on LHRH?
So vast majority of these patients had were triple negative breast cancers, so they were not on any endocrine therapy. So I guess the number of pregnancies we're seeing in this group are because of that. And they're all young patients.
So very nice update. I think this was one of the good abstract to see the follow-up. The question always is how do you integrate this with in ER positive and ER negative, with everything else now being standardized, like immunotherapy in triple negative versus capecitabine if you have residual disease. So how are you fitting this in your triple negative and then in the ER positive with the CDK4/6 story as well?
Thank you. To be honest, when I looked at this abstract, I thought twice and I was thinking it's pretty straightforward, approved drug. There is nothing new here. I think we're just presenting an elongated follow-up. And what questions Dr. Hassan can ask? So I think this is a very common question which has been asked in different meetings in the hormone receptor positive, HER2 negative breast cancer, if they are BRCA mutation positive, and they are eligible for PARP inhibitor. I think it's a common practice to use PARP inhibitor first for 12 months, and a discussion about use of CDK4/6 inhibitor should be very individualized, really. And in the triple negative breast cancer patients, it's safe to use olaparib with immunotherapy. Patients who are BRCA mutation positive, I think it's fair consensus that rather than using capecitabine, you would go for PARP inhibitor. Dr. Nohar's comment.
I think the CDK4/6 adjuvant trials allow starting the patients on CDK4 16 months from the time of surgery. So it'll give you plenty time to finish the olaparib before you go over.
Absolutely.
Thank you, Dr. Farouk.
Thank you.
We come to the last but not the least. Most of you probably do not know that KCCC, which is Kuwait Cancer Control Center, was the first comprehensive cancer center in the region. This was established in the middle of the 70s or beginning of the 70s by two great people, Dr. Yusuf Omar and Dr. Samir Mtawa, God bless their souls. These people did a good job, really, and everybody was proud to work with them. Dr. Nouri, coming from that center, bringing all that history with him, and I'm really glad to present you Dr. Nouri from that center.
Assalamu alaikum. Thank you for the introduction. And thank you for the short history also about the KCC. Salah KC has a lot of history. Dr. Salah Fayaz also, who I think we all know, works there before I was born, actually. So it's quite something. So I will talk about efficacy, and I want to thank Dr. Aida and the society for inviting me, really صراحة. أنا شايف بعد اليوم المؤتمر في عنصر نسائي قوي. And this is encouraging. Like كانوا هني and they moved into the middle now. So I will talk about efficacy and safety of trastuzumab deruxtecan, TDXD, versus physician's choice of chemotherapy by pace of disease. So basically endocrine resistance, progression on prior endocrine-based therapy. So additional analysis from the Destiny DB06. These are the disclosures that were presented by Dr. Aditya Bardia. And so this is the design of this trial, Destiny Breast 06, study design. And basically, these are patients, HR positive metastatic breast cancer with HER2 low or ultra low. And they are chemotherapy naive in the metastatic setting. And they had prior lines of therapy in the endocrine, either 2 or more endocrine therapy with targeted, or 1 line, and they had either a secondary resistance or a primary resistance. They were randomized in this trial, as we know, to TDXD. And versus chemotherapy as physician choice 1-to-1. And what they looked at here in this analysis, basically, they were looking at in a subset of patients based on the progression on endocrine therapy, so the pace of the progression. What they looked at the PFS, PFS2, and some other secondary outcomes. And if you look at the baseline characteristics of these patients, they were 30% de novo, liver metastasis was 67%, visceral disease was 85%, primary endocrine resistance was around 30%. And if you look at the objective, so basically they are investigating the benefit of T-DXd in patients with different responses. So basically here, primary versus secondary resistance. Also, they were looking or assessing the efficacy of subsequent therapies post-progression on T-DXd and the chemotherapy choice as per the physicians, which is basically time from randomization to second progression. So basically measuring PFS2. And also finally, understand the benefit of the T-DXd patients with varying burdens of illness. So baseline tumor extent and location. So number of metastases and so on. Now, in the first point, objective, looking at the PFS in this exploratory time to progression and endocrine resistant subgroups. So whether the progression was in the first line less than 6 months, so this is primary progression, or 6 to 12 months, or after 12 months in the first line metastatic setting. You can see clearly here favoring the T-DXd. So it improved the PFS versus the chemotherapy as per physician choice, regardless of the time of progression on the first line endocrine therapy plus CDK4 inhibitors or the type of endocrine resistance. So whether it was less than 6 months, more than 6 months, endocrine resistant, primary or secondary, as you can see in the table down. Now, looking at the objective response rate and duration of response in the exploratory time to progression and endocrine resistance subgroups. And again, we see here that T-DXd improved the objective response rates and the duration of response versus the chemotherapy as per the physician's choice across all the time to progression subgroups in patients with primary and secondary endocrine resistance, as you can see here, whether less than 6 months, 6 to 12 months, or more than 12 months in the first line, and whether they have primary or secondary resistance in these outcomes. And looking at PFS2, so in the intention-treated population and this exploratory time to progression, you can see here favoring the T-DXd compared to the chemotherapy versus physician choice. And then also if you look at the down table where whether it was less than 6 months, 6 to 12 or 12 months, you can see that there's a delay in the PFS2, which was clinically meaningful in favor of the T-DXd in the intention-treated population and the chemotherapy as per physician's choice. If you look at the PFS in further exploratory disease burdens, so whether the patients had less than 3 local metastatic sites or more than 3 local metastatic sites, you can see that the favoring here is more in the less than 3 local metastatic sites, but in both groups. So there is a favoring of T-DXd compared to the chemotherapy. And then also if you look at down here the table, so in the subgroup analysis, whether they had liver metastasis or the baseline tumor size or the visceral disease, whether they had or not, it was all in favor of the T-DXd. So PFS benefit with T-DXd was observed regardless of the disease burden, with notable efficacy in patients with lower disease burden. And finally, if we look at the safety in the exploratory time to progression and disease burden subgroups, we do not see anything that we do not know that has been reported with this drug in the past. So the safety profiles for the T-DXd and the chemotherapy in the time to progression and disease burden subgroups were in line with the overall safety population. So as you can see here, whether 6 months or 6 to 12 or whether they have 3 metastatic sites or more, it's all within the same side effects that we have been familiar with in the past. So they concluded that T-DXd demonstrated a clinically meaningful efficacy benefit versus the chemotherapy regardless of time to progression on the first line endocrine therapy plus CDK4/6 inhibitor. So a median PFS 12.9 to 14 months. This included patients with rapid progression. Remember, primary resistance less than 6 months as per the ESMO definition. And remember, I told you in the first slide there were 30% of that population. Efficacy outcomes were consistent in patients with primary and secondary endocrine resistance with a median PFS of 12.4 to 13.2 months with T-DXd. PFS2 favored TDXD over the chemotherapy in the overall population, with a median PFS2 of 20 months, and in all the time to progression subgroups, with a median PFS of 17 to 20 months, indicating a clinically meaningful second and progression delay with TDXD. And TDXD also demonstrated efficacy regardless of the disease burden, with a more than 5 months improvement in the PFS compared to chemotherapy in patients with lower disease burden. And then finally, safety profile in the subgroups were consistent with the overall safety population. And thank you. And I want to say something, you know, once a picture goes on the net, you can never get rid of it. I have been trying 3 years to get rid of this picture. I have a professional picture, and I swear it's like a virus. You can never. I tried دزيت مسح كل everybody, and I still get to see this picture. Thank you. No coffee break? Okay. So, would like to present the next moderators for the early breast cancer management. It's a mini surgical session. Dr. Ernest, he's a consultant oncoplastic breast surgeon, Sheikh Khalifa Medical City. He's going to moderate the next session. Please welcome him.
Thank you. This is the hardcore family sitting here. I'd like to compliment everybody and thank you. When I start, well, let's start off. There's a slide before. Yeah. My co-chair, I'd like first to give a word of appreciation for my co-chair. I'm honored to sit next to her. She deserved the Emirates Women Award, but we have a lot of power women here in the room. May I highlight some, Dr. Aida and Dr. Omar, for that they're really like power women to organize this Congress. And as men, we know that most women have two jobs, take care of the family and being a doctor. And I'd like to give a special thank for that. So having said that, like we're doing the last main course, I designed a very short starter, and we saw this morning where we saw the fight between the radiotherapist and the medical oncologist. And actually, they've been competing for the women's favor already for decades. And I'd like to bring you back to studies like more than 20 years ago, already addressing and questioning the fact that can we do less radiotherapy in older elderly women with low-risk breast cancer, or can we even abolish tamoxifen or even abolish axillary lymph node dissection? Now, as surgeons, we don't have that much issues with doing less, means that we have to stand for a shorter time in the OR. But as was nicely pointed out, like even though these studies were like presented and published like 15 or 20 years ago, 15 years later, this nicely article, which I really can recommend, published in the Radiation Oncology, mentions that breaking up is hard to do, specifically for radiotherapists. And actually we're trained as doctors, whenever there is a new treatment supporting that adding this treatment can do better, give better results, we're very quick in adding this treatment and stuffing our Christmas tree until it in the final end, this patient will fall over. And actually we should dismantle this tree as much as possible. So we're going to talk this session, for instance, about DCIS, ductal carcinoma in situ. And for some of us, it's only ductal carcinoma in situ. But for others, it's ductal carcinoma in situ. So bearing in mind that from the left to the right, this is a normal duct, by the way, this Dutch language, lined off by one layer of columnar cells and lined by the basal membrane, developing sometimes to like a little bit messy, like ductal hypoplasia or atypical ductal hypoplasia, and when it really gets messy, we call it DCIS. But it's only invasive ductal carcinoma when it crosses the basal membrane. That's just basic knowledge. But it's good to bear in mind that almost 70% of DCIS will never progress to invasive breast cancer. So let's meet each other somewhere in the middle. And I think that the national flag of the UAE gives like a very nice example of this one. And do we dare finally to leave the axilla untouched? And Dr. Bashir is going to talk about this. And actually we did already 50 years ago, when we randomized patients for mastectomy with observation, radiation, or complete axillary lymph node dissection. And based on physical examination of the axilla, there was no difference in node-negative patients with regard to recurrence and overall survival. Actually, we already did leave the axilla alone 50 years ago. And as I'd like to repeat the quote of Dr. Giuliano in 2016, the smart cells go by the blood. And with this last word, I'd like to give the podium to Dr. Ibrahim. He doesn't need any introduction. He probably is going to tell that maybe we can do even less radiotherapy, but we'll hear from him. Dr. Ibrahim.
So, thank you so much. Thank you for hanging out. Very nice introduction, Dr. Ernst. I got to give you A for effort. But I'll tell you one thing. You just mentioned radiation. We're trying to downstage. I'm going to show you how much radiation is easier than 5-year or 10-year of hormonal therapy, for the sake of women, with the same picture that you used, okay? But I'm not going to change any of the slides. So this is a phase 3 trial. This is an interim analysis of phase 3 trial that was presented by actually a dear friend that I happened the pleasure to meet, Ikro Maitini. He's from Italy, and he's pioneering a lot of the breast cancer studies worldwide. So this is the European trial, which also Dr. Saeed mentioned earlier. So this is exactly the same question. Exclusive end radiation, we make life simple. 70 plus radiation versus hormonal, unlike the previous studies that had some radiation and hormonal therapy. So this is the pre-planned interim analysis of this phase 3 trial. This is ICRO's conflict of interest. So some history. So breast cancer in older women, there is a lot of prevalence of luminal breast cancer. Usually we try to reduce the treatment burden with a balanced treatment between efficacy and, most importantly, the health-related quality of life. If we are really talking about personalized medicine and we're talking about these elderly women, we need to look at their quality of life. So the current standard is breast conserving surgery followed by radiotherapy, hormonal therapy for ER-positive tumors. So challenges from the previous studies is that the older studies that omitted radiotherapy that Dr. Ernst mentioned, they showed that omission has increased risk of local recurrence. However, there's no survival benefit, obviously. Side effects with adherence and persistence of hormonal therapy was also not tackled very clearly. So there is lack of data of comparing single modality radiotherapy versus hormonal therapy when it comes to the health-related quality of life for these elderly patients. So the objective, very simple, evaluate the health-related quality of life and ipsilateral breast cancer recurrence rate between radiotherapy and hormonal therapy. And remember, this is an interim analysis. Again, radiation oncologists, we like things very simple. This is a one-to-one randomization between exclusive hormonal therapy versus exclusive adjuvant radiotherapy. And these are the primary endpoints. And this is the stratification. So these are all luminal breast cancer, more than 70, the kind of patients that you can omit radiotherapy. But however, are you sure they're going to be on hormonal therapy? So again, talking about de-escalation, all the previous trials, they used to give 15-25. Now we are going to 14-25. And interestingly, in this trial, they started using partial breast radiotherapy as well. The most commonly current one in practice is 30-5 every other day or every daily based on ICRO's Florence trial as well. Hormonal therapy was aromatase inhibitors or tamoxifen for 5 to 10 years based on the physician's choice. So again, this is the statistical analysis. So this is an interim analysis for 152 patients. So please take the results of those up until we have the final analysis. So these are the rules for stopping the trial if there is more than 2% risk of recurrence or more than 7% risk of metastasis. So this is the patient population. You can see that the patient is fairly well distributed between the radiation alone arm versus the hormonal therapy alone arm. And this is kind of also stratification based on the age and the score as well. So this is the patient characteristics, again, just for the sake of time. I'll go over it quickly. So they were fairly well matched. So now this is the important part. Okay, this is where we look at the outcome. And these are all actually outcome comparing radiation arm with hormonal therapy arm. So you can see that the decline in the patient's quality of life is significantly seen more when patients are on hormonal therapy compared to radiation therapy. So again, you can see that between minus 1.1 to minus 10, so this is 10 times more downside treating patients on hormonal therapy alone compared to radiation alone. As well as the adjustment based on the score, just for the sake of time, I'll show you also. So in all so when you look at the quality of life related questionnaire, the functional status as well, you can see that in most of the arms, the hormonal therapy did worse than the radiation therapy. I'm talking about physical functioning. These were not statistically significant as of yet. But you can see that physical functioning, role functioning, emotional functioning, cognitive functioning, and social functioning were mostly favoring radiation as compared, except for role functioning, as compared to hormonal therapy. So again, radiation was better in physical functioning, in emotional functioning, in cognitive functioning, and in social functioning of the patients. So, sorry, I just wanted to go back. Oh, sorry. Again, also looking about the fatigue, nausea, pain, dyspnea, insomnia, you can see that radiation is doing better in all the arms. So why subject your patients for 5 or 10 years of hormonal therapy with all these side effects if you can treat them with 5 fractions of radiotherapy to their partial breast with significantly less side effects? This one, I believe, is actually flipped. The worse should be better and better should be worse. But again, these were all non-significantly functioning, which was a body mass index, sexual functioning, breast satisfaction, and future perspective. Now, if you look at the quality of life, another questionnaire, obviously you can see systemic side effects is more with hormonal therapy. You can see that the patients who had endocrine therapy symptoms was significantly more with endocrine therapy. Skin mucosa symptoms was also worse with hormonal therapy, and sexual dysfunction was worse with endocrine therapy. So endocrine therapy arm shows statistically significantly worse systemic therapy and skin mucosa symptoms than radiotherapy. And these are the only 2 statistically significant, again, on the interim analysis. Survival outcome, as Dr. Saeed mentioned, there is no difference in terms of survival and outcomes. And there was no recurrences in both arms. In terms of adverse events, you can see that the treatment-related or treatment-emergent adverse events, which is highlighted, was significantly worse in the patients treated with hormonal therapy as compared to those patients treated with radiation therapy. Again, if you look at the details of those, so the arthralgias, joint pain you had more grade 3, so you had zeros, grade 3 and grade 4 in the radiation arm, but you had grade 3 and grade 4 arthralgias or joint pain in the endocrine arm. You also had fatigue grade 3 in the endocrine arm compared to 0 in the radiation arm. Breast pain obviously is higher in the breast, but grade 1 or 2, luckily no grade 3 or grade 4. So again, these for people who criticize the radiation, with new modalities of radiation, you don't get significant late side effects on the patient. Bone pain was also significantly worse in the endocrine therapy arm. So again, 22.5% of patients on endocrine therapy actually switched their treatment, and 12.4% actually discontinued their treatment. So again, this is a currently still open phase 3 trial, mostly in Italy and in Slovenia as well. And this is, again, with the limitation being a subset analysis of, an interim analysis of the initially planned cohort. The median follow-up is still 2 years. Longer follow-ups is pending. And of course, we cannot be generalizing all this treatment for all women. So in summary, radiotherapy offers better health-related quality of life score for patients than hormonal therapy at 2 years. It has lower incidence of treatment-related adverse events compared to hormonal therapy. And there are, luckily, so far, no signs suggesting stopping the trial. So there is no increased ipsilateral recurrence or distant metastasis or death by treating with radiation versus hormonal therapy alone. So this is still ongoing. They're still recruiting patients. So the take-home message from ICRO is that radiotherapy or hormonal therapy may be viable as a single modality treatment option, emphasizing the need of multidisciplinary, and this is a very nicely written summary, emphasizing multidisciplinary and patient-centered personalized care. But again, please keep in mind that not all women will tolerate the 5 or 10 years of hormonal therapy you're planning on, and doing 5 fractions of radiotherapy over a course of 1 week is much easier. With that, thank you for the patients and the caregivers and for the organizing committees for this. Thank you. Questions now or later?
Shall we take a few after? Oh yeah, were the questions here?
Okay.
Me and Dr. Aida, we were in the symposium. This study was presented exactly to give the opposite, that you could do hormonal therapy without radiation, you know. But well, indeed, my conclusion when I heard the data is that it's completely the opposite. Yes, I can save my patients 5 or 10 years of suffering with just a week of radiation in the hands of an excellent radiation oncologist I trust. So see, we are very open to improving the outcome for our patients and side with you when you do help.
Also, I have a comment as well on that line, is just because, first of all, in real life, we have patients receiving both. So this trial is telling you definitely you need to omit radiotherapy. Agreed. That is number one. Number two is that radiotherapy is going to be very expensive, whereas letrozole is like 200 dirham each month. So that
No. The cost of 5 fractions over 1 week is much less than a cost of 10 years of hormonal therapy.
Okay, fair enough.
Dr. Bashir?
Dr. Nuhad also is there. Yeah, go ahead.
I have the problem omitting tamoxifen because of the prevention role on the other breast.
So again, totally agree, but this trial, again, these are patients 70, more than 70. This trial, actually, if you look, they still did not show the contralateral breast recurrence, but there is no difference in terms of late outcome.
Yeah, it is only because of very short follow-up, 24 months. And number 2, breast cancer is disease of the elderly. So 70 years does not rule them out from developing another breast cancer.
Yeah, we have to wait still. So you would still offer hormonal therapy to all your 70 plus?
Yes, yeah, for prevention.
Even if you have radiotherapy for 5 fractions partial breast?
Yes.
For the contralateral breast?
Yes. If it is DCIS, I give tamoxifen. If there is microscopic or obvious invasive ductal, I give AI.
Okay.
Real quick, Nuhad, how much I respect you, and usually we agree. Allow me to disagree, because you are absolutely correct in terms of the contralateral reduction in the risk of breast cancer, but there has never been OS benefit. you reduce the risk without OS benefit. And for those 70+ years, how many times, at least in my practice, I had to stop hormonal therapy because of side effects, cognition, or real side effects.
As I respected your disagreement, I respect your disagreement, but it's a standard of care to give prevention tamoxifen.
Dr. Bashir? Is the mic working? Just can someone check, please?
Yes.
Yeah.
I'm actually going to side on the oncologist side this time because there are different treatment. One is local and the other one is systemic. I don't know. This is only 2 years. We know the failure usually is not local failure. It's a systemic failure. So when you are treating with radiation, you are not preventing anything in terms of recurrence. So along the same thought of Dr. Nuhad here, he's preventing the other contralateral breast cancer. With 2 years, we know with hormonal positive cancer, you don't know till 10 years or 15 years later. So I'm concerned about this. Honestly, if I designed this study, I would add one more arm where they don't get anything, no radiation and no hormonal, and see what's the difference.
I think I hear you, and that's why I think they put what are the points that they will stop the trial. So if there's more than 2% risk of recurrence or 7% of distant metastasis. I don't know the numbers, obviously based on statistical analysis. And adding a third arm of doing nothing, it might also be very mind intriguing, but I don't think it would be easy to accrue on this, right? So to do nothing for this. But I hear your point. But I still think 5 days of radiation is way more cost effective and easier than 5 years of
But it only has local control. It doesn't do anything to the system.
Well, we don't know. I think radiation does have something more than local control.
Dr. Aida, final. And then we close.
Actually, this is a very good study, and it triggers a lot of questions. And I think just it's maybe a proof of concept to personalize therapy for the patient. 70+ with life expectancy like for 2 years. It's different than 70+ who I think will make it to 100 years. So I think it just gives us room to discuss with the patient and personalize therapy according to the patient's factor.
Yes, okay, thank you. With that, I'd like to give the mic to my dear colleague, Dr. Naher, to introduce the next speaker, please.
Okay. Thank you, Dr. Ibrahim, for this great informative talk. We'll move to the next session. It's my pleasure to introduce Dr. Maha Sindi from Bahrain. She's a medical oncologist and the head of the training department in the Bahrain Oncology Center. Please welcome her to the floor. She's going to talk about impact of tamoxifen after breast conserving surgery, especially for DCIS. The floor is yours, Dr.
So I think we're keeping with the theme of the session of DCIS and tamoxifen. So thank you, Dr. Aida, Organizing Committee, for your invitation. It's an absolute pleasure to be with you today. So I'm here asked to talk about the impact of tamoxifen only after breast conservative surgery for good risk ductal carcinoma in situ. This is a combined result of the NRG Oncology, RTOG 9804, and the ECOG Akron E5194 trial. واحد next. The green one. Okay, there. Okay, so this is the disclosure. So the rationale of the trial is that the impact of radiotherapy on ipsilateral breast cancer recurrence after breast conservative surgery for DCIS was the subject of extensive prior and ongoing research. The NRG RTOG 9804 showed that radiotherapy reduced the ipsilateral breast cancer recurrence by half at 15 years in good risk population. However, the impact of endocrine therapy is less well established. There is historical data that shows variable ipsilateral breast cancer reduction in overall DCIS and invasive. However, most modern studies have left its use up to the discretion of the treating physician, and it's really highly variable across practices. And I can say that when we were treating patients in Dublin, we never saw DCIS in clinic, whereas we are referred to every DCIS here, even if the patient is 80 years old. So with that, so this is the background, the NRG, RTOG, and ECOG Akron studies, both subclassified DCIS into risk groups after breast conservative surgery based on the size, the grade, and the margin width. So they enrolled good risk DCIS, which they defined as the size less than 2.5 centimeter, grade 1 and 2, the margin being more than 3 millimeter, to whole breast radiotherapy or doing nothing. And similar criteria in the ECOG-ACRIN trial, which enrolled 2 prospective observation cohorts without radiotherapy, one with the same good risk characteristics as mentioned previously. And in both trials, the use of tamoxifen was left to the discretion, but was tracked by the study. So this is an ancillary analysis of both trials assessing the role of tamoxifen in this good risk group that has not received radiation on the ipsilateral breast cancer recurrence risk. So if we look, this is the cohort, and just if they took these patients that were analyzable, these are patients who did not undergo radiation. They were only treated with either with or without tamoxifen based on the discretion of the treating physician. So out of them, they combined the analysis into, as you can see here, the low intermediate grade DCIS, tumor less than 2.5 centimeter. They ended up having 878 patients. Out of them, 378 who were treated with tamoxifen and 500 who did not. So they combined the databases, was created. They distributed the patients and DCIS characteristics by tamoxifen use and were compared using the chi-square test. They looked at the ipsilateral breast cancer recurrence, both invasive DCIS and contralateral breast events, and were estimated by the cumulative incidence method and distribution between tamoxifen use, were compared using the Gray's test. They used a two-sided significance level of 0.05, and they used a multivariate analysis regression that looked at the effect of factors in addition to tamoxifen use that might be associated with the endpoints. So let's look at the patient's characteristics. As you could see here, almost half the patients came from both subsets of the cohorts. Most of the patients were above the age of 50, as you can see, and you look here, most of them had a margin of more than 3 millimeter. And if we look at the pathological size, most patients had a tumor size less than 5 millimeter. And when we look at the grade, the majority of patients had grade 1 or 2 DCIS. And just looking at the results, this is the overall ipsilateral breast cancer recurrence based on tamoxifen. And you can see here, this is the 15-year ipsilateral breast cancer recurrence that was reduced from 19 to 11.4 with the use of tamoxifen after a median follow-up of almost 15 years. And if we look at the types of ipsilateral breast cancer recurrence, we look at the DCIS, we see a very modest improvement with 8.1 with no radiation versus the use of tamoxifen, 5.5%. And when we look at the invasive breast cancer recurrence, we see a reduction of almost half, 11.5% versus 6%. And as opposed to what we have thought, that tamoxifen reduces the risk of contralateral breast cancer, but this is in DCIS, not invasive breast cancer. Okay, so we can see that as opposed to what we thought, there is no actual significant difference here. So when we're looking at really which patients really benefit from the use of tamoxifen, it's really pathological size and the grade of DCIS. And again, and this is looking at the factors that improve the ipsilateral breast cancer recurrence. It's really the use of tamoxifen and tumor size being significant. And again, when we divide them into invasive or DCIS, for invasive, it's tamoxifen use that's reduced and the DCIS grade, whereas for DCIS, ipsilateral breast cancer recurrence, it's tumor pathological size. And this is the subgroup analysis, looking at the subgroups that we have mentioned. So in conclusion, this exploratory analysis combining the two data have demonstrated that in patients with good risk DCIS by the clinical criteria treated without radiation, adjuvant tamoxifen reduced the overall ipsilateral breast cancer recurrence and invasive breast cancer recurrence, but not DCIS or contralateral breast cancer events. And in the absence of survival impact in this adjuvant therapy, the decision to recommend endocrine therapy in the setting of radiotherapy omission remains a shared process with the patient and physician. Their ongoing study of molecular profiling to inform regarding radiotherapy decisions should also evaluate the impact of endocrine therapy decision, particularly in those not receiving radiotherapy. And with that, I'd like to thank you.
Any questions? I think Dr. Hassan just lost his voice. If somebody found it, leave it there, please.
DCIS, yeah, it's only DCIS, not invasive breast cancer. So I think the main benefit is it's really in reducing the invasive breast cancer recurrence, and also in these patients that are good risk, as mentioned in the trial. So I don't know about you, but our surgeons tend to refer all DCIS to us for treatment.
Cancer in the, but also the B12 shows that also reduces DCIS, but B12 was a much bigger and more highly powered study, so I'm not sure whether this one override the B12 trial, but still, based on this, I would still give tamoxifen.
Yeah.
And Dr. Brahim.
And Hassan agrees with me.
No, I agree on tamoxifen, but I want to ask Dr. Brahim, so are you ready to, these patients with less than 2.5, to say goodbye to radiation?
Yes, if we have a low decision RT score. So we have now, we're looking at Oncotype DX.
Yes.
It's actually a 12 gene marker for DCIS. If it's low, we are totally fine with this. So, but the interesting slide that I show is the contralateral reduction was not affected by tamoxifen. So going back to my previous presentation, 5 fractions of radiotherapy is much easier than 5 years of hormonal therapy that might not prevent a contralateral breast reduction. Dr. Ibrahim, my mentor.
Thank you.
Thank you, Dr. Maha, for this great presentation. And going back again to the radiation oncology, so our next speaker will be Dr. Reem Ujaimi. She is a radiation oncologist specialized in breast and gynecology tumors in King Abdulaziz University Hospital. And her talk will be about the impact of post-mastectomy radiation therapy in intermediate risk breast cancer, if it has impact on overall survival. Please, Doctor.
Thank you very much for the introduction, and thanks for everybody for staying this late. I'd like to thank Dr. Aida and the Emirates Oncology Society for the invitation, and it's my pleasure to be presenting the long-awaited result of the Supremo trial on behalf of the trial investigators. And I'd like to thank Dr. Kunkler. His slides are very simple, so this will be a quick presentation and everybody will be pleased. So post-mastectomy radiation therapy has been established as a standard of care for node-positive patients, particularly N2 patients and those with T3N1 disease, since the publication about 30 years ago of the Danish and Canadian trials that showed survival advantage from the addition of radiation therapy. Those trials have included patients with N1 disease and high-risk node-negative patients. However, because of criticism over those trials, including the intensity and type of systemic treatment used, as well as the number of lymph node dissected, particularly in the Danish trials, and the high risk of local regional recurrence in comparison to other series, the use of post-mastectomy radiation therapy in N1 patients or high-risk node negative has been questioned, and as such, this trial was initiated to investigate the role of post-mastectomy radiation therapy in this subset of patients. So the trial includes patients who has PT1N1, T2N1, or T3N0, histologically confirmed invasive breast carcinoma. Patient with high negative, node negative high-risk breast cancer, including T2N0, are enrolled if they have grade 3 or lymphovascular invasion or both. They had to go for simple mastectomy with axillary staging procedure. The mastectomy has to have 1 millimeter of clear margin at least. And I'd like to mention that the trial protocol included patient with skin-sparing mastectomy and immediate reconstruction as well. If axillary nodal clearance is positive, with 1 to 3 positive lymph nodes, then a minimum of 8 lymph nodes has to be removed. However, negative nodes can be established based on sentinel node biopsy only, and for patient had to be fit for adjuvant or neoadjuvant chemotherapy if indicated, obviously adjuvant endocrine therapy if indicated, and post-operative radiation, and they had to be consented. So the primary endpoint of the study was overall survival at 10 years, and this is what I'm presenting today. Secondary outcomes include local and regional recurrence, disease-free and metastasis-free survival, cause of death, acute and late morbidity, and quality of life, and cost effectiveness. And this presentation is about the primary endpoint as well as the two first secondary endpoints. So the trial was powered to detect about 7% difference in overall survival with 5% power, and this required about 600 events. So patients were randomized to no chest wall radiation versus chest wall radiation, and the analysis was based on intention to treat. The radiation in this study was conventional with 50 grain 25 fraction, but also with hypofractionated 40 and 20 and 15 or 42 and 16. So these are the basic patient characteristics. The patients were equally distributed among the trial arms. About 20%, 25% were high-risk node negative. Oh, sorry. How do I go back? The red one? Okay. 25% were node negative. About 52% had high-grade disease, and a good proportion were younger patients, with 15% being younger than 45 of age. The tumor was mostly T2 with 68%, and 20% of the population were about HER2 positive. Only 10% were triple negative, and otherwise there were no special characteristic to be mentioned. So this is the outcome of the survival, the main outcome of the study, the overall survival at about 9.5 years of median follow-up. And as you can see, there was no difference in overall survival between the two arms. When they looked at the survival as a function of nodal status, that was pre-specified analysis or population, there was no difference, as you can see, whether it was node positive or node negative in terms of the effect of radiation on overall survival. When they looked at local recurrence, those who had chest wall radiation did benefit from that addition. The magnitude of that in a relative term was significant, about 50%, with a hazard ratio of 0.45, and it was statistically significant. However, if you look at the clinical significance, this was very small. It cut it down from 2% to 1%, so a very small absolute benefit. Local recurrence as a function of nodal status also did not show a significant difference between those who received radiation versus no in terms of node positive versus node negative. And regional recurrence also has not been shown to be reduced significantly with the addition of radiation treatment. At least there is no statistical significance, and the magnitude clinically was also very small. Regional recurrence as a function of nodal involvement, again, did not show any significant difference between the two arms. And in terms of metastasis-free survival and disease-free survival, again, there was no significant improvement with the addition of radiation therapy. So in conclusion, patients with 1 to 3 positive lymph node or high-risk node negative adjuvant chest wall radiation with optimal systemic therapy does not improve 10-year overall survival. It results in a clinically insignificant reduction in 10-year chest wall recurrence, less than 2%, has no impact of disease-free survival or metastasis-free survival. The author noted that they believe that this incremental improvement, that this result reflects the incremental improvement in multidisciplinary care, probably explaining the result, and that adjuvant chest wall should be omitted in most patients meeting the eligibility criteria for Supremo. And these are their acknowledgements.
Dr. Reem, thank you so much. To throw the question right away in the audience, Dr. Ibrahim, do you think this is good news for patients undergoing mastectomy with direct implant reconstruction, not to have any clinical benefit, but from the post-mastectomy radiation and have their breast supple?
So this is definitely a mind-intriguing trial, and I think we have to take the trial results very positively. I don't think you can argue with this, but I want to just highlight one thing. In those patients, all of the almost node positive on Sentinel, almost all had dissection. So you cannot apply the Emirates in this trial. So if you are planning to do a dissection on 45% of your patient, which is what they have here, then I'm okay omitting radiation, but you need to dissect in 45% of those patients. Because if you had a node positive disease, you cannot apply the Emirates in this case, right? So you cannot, omit dissection. So this is the only, I would say, loophole around this trial.
But then we have selective axillary dissection with axillary reverse mapping. Who's this guy behind you? I don't know him.
I was going to raise the same point. I think you have to be careful with this trial. It started 10 years ago, and now the practice has changed. So many times we say we don't want to do dissection because we will depend on radiation, especially in positive nodes. So I think that point is well taken, rather than take the conclusion of the trial and move on and say, I don't want to give any radiation. That's dangerous. And I think, if I recall, Dr. Zaidan raised the same question during the San Antonio, and the presenter agreed with him that this will not apply to those like Emirates, etc. Right?
Yes, absolutely. But you'd be surprised that we still see lymph node dissection in those patients. Yes. So I think this trial has some role in the practice.
Absolutely, absolutely. Because the teaching was any positive node, give radiation, because they had the meta-analysis that even one positive node benefited some. So
I never actually heard. Yes, you talk about it, but I don't recommend it. I have to mention it, Ibrahim. I never recommend it. And of course, none of my patients with up to 3 lymph nodes received post-mastectomy radiation, because I'm not convinced that the long-term evidence is really sufficient to expose them to this added burden.
It was only after meta-analysis that they said that. Because the original trial were not positive.
To answer your concern, the loop, I feel bad for you, my friend. This loophole, what is the proportion, or what is the likelihood of having positive nodes? Oh my God, he broke my heart. I can't go on.
70%. No, honestly, all these, yes.
We're trying to kill the last radiotherapist in the business.
I thought everybody would be pleased with this presentation. You're still not pleased.
They're happy, but I'm killing the presentation.
I'm trying to protect Dr. Ibrahim before, because we have more talks that he will also have to answer. So
I was on his side just a minute ago, but this one, what is the likelihood of having positive nodes when you have Up to 3 lymph nodes.
So sorry, or Anjad, I was texting. So your question is, what's the value of adding radiotherapy in 1 to 3 positive lymph nodes?
No. What is the chance of having really further positive nodes when you are doing sentinel node and it's negative? That's my question.
That's a question for the surgeons.
No, that's a question that we learned from data. It's less than.
And I can answer.
And
I can answer you what is the value of post-mastectomy radiotherapy in 1 to 3 positive lymph nodes.
There isn't.
Of course there is. There's a meta-analysis.
I know, meta-analysis. It is, but it's minimal actually, not worth the added burden of giving radiation therapy to a lady.
What's the burden of adding radiation therapy?
Listen.
With all due respect, shall we move on? Thank you so much. Shall we do also the appreciations afterwards, and then we keep the discussion going, or there? Wow.
With dissection.
Okay, thank you, Dr. Arim, for the informative presentation. Now I'm going to present Dr. Rita, who doesn't need any introduction. Dr. Rita, she's a friend of mine, well-known consultant breast oncoplastic surgeon and obstetric gynecologist with over 20 years. She's going to talk about early oncologic outcomes following active monitoring or surgery. Welcome to the stage, Dr.
Thank you, Mati. Thank you. Thank you so much, everyone, for staying late and continue with our dear presentations. So I would like first to thank Emirates Oncology Society and Breast Cancer Working Group, Dr. Aida, for inviting me to present this very challenging topic. Again, with Ernest, we have a lot of challenging topics with the de-escalation, so not only radiotherapy, but also surgery, and challenging not only for patients, for doctors as well. Like we're changing our practice from in the axilla, from complete clearance to sentinel node to omitting, and surgery the same, from like doing surgery to omitting surgery. So I'm happy to present this paper from Dr. He Wang. She presented at San Antonio about the COMET study, primary outcomes following active monitoring or surgery for low-risk DCIS. So it's a very challenging, again, study and practice for the future. As a background, as Ernest already mentioned, so ductal carcinoma in situ, in place it means. So it is a pre-invasive, a pre-cancer situation. In the United States, it's estimated around 56,000 newly cases after every year, and the treatment usually is surgical excision with radiotherapy or mastectomy to prevent progression. Now, we have to know that DCIS may or may not progress into invasive. I had the privilege to work for my PhD at Memorial Sloan Kettering on DCIS invasiveness, and we looked at PI3K pathway and other biological factors, and all the findings were contributing to the fact that this is not a necessary precursor to invasive. So it may or may not develop into invasive cancer. So why not looking at the opportunity to check safety of active monitoring, the way they do already for prostate invasive cancer. So this is what the rationale behind the study of the COMET. So the COMET is a prospective randomized phase 3 non-inferiority trial. The two arms including randomizing patients under guideline concordant care. It means that they have the usual care for DCIS, so those are patients with low-grade DCIS, including in this arm, and they had either surgery, breast-conserving surgery with or without radiation or mastectomy, and the other arm is active monitoring. So they were performing mammogram every 6 months, and if any evidence of change in the imaging, then they had biopsy. The endocrine therapy was permitted for both arms. The primary outcome for the study was any invasive cancer detected. In the GCC group at the time of surgery or at any recurrence, in the active monitoring at any change of the imaging, doing a biopsy and discovering invasive cancer.
They looked as a primary outcome at 2 years cumulative rate of ipsilateral invasive cancer at any time following the randomization. So who was eligible? Any patient, any female more than 40 years old with a new diagnosis of DCIS. It can be unilateral or bilateral. The pathology criteria was confirmed by 2 pathologists. DCIS without invasive, it was nuclear grade 1 or 2 and ER positive. 2 sites of biopsy were required if more than 4 centimeters. The randomization was stratified by age at diagnosis, by maximum diameter of microcalcification, and by the DCIS nuclear grade. So a few words about the statistical analysis plan. It was a primary outcome looking at 2 years cumulative rate of invasive cancer following randomization in both groups. The sample size was based on the assumption of around 30% of patients non-adherent to the initial randomization. And they looked at the 2-year cumulative rate of invasive cancer. Now, one-sided non-inferiority bound of less than 5% higher rate in the active monitoring was the comparison they did. Now, because they assumed that many patients will not adhere to the initial randomization, they did intention to treat analysis and per protocol analysis. The endpoints of the study was as primary 2 years, as I mentioned, ipsilateral invasive cancer rate. As secondary endpoint mentioned in this study, in this presentation, the 2 years mastectomy rate. Now, there was also, they looked at the quality of life of the patient and psychological outcomes. They were shared at San Antonio in another presentation. Now, this is the flow chart showing how the number of patients and how they were separated in these 2 randomized groups. And you can see 484 were included in the 2-year ITT analysis in the active monitoring group, and 427 in the per protocol. Now, interestingly, look at the GCC arm, and 473 in the ITT, it means initial randomization. You can see only 236 were in the per protocol. Many have switched the arm during the study. Looking in the ITT, intention to treat analysis, so all patients were 957. If we look at them, most of them, they were more than 55 years old, more of white descent, most of them, DCIS grade 2, and there was, like mostly, they were healthy patients in the group. There were a few morbidities, but they were in general a healthy population. When they did the primary endpoint of 2 years cumulative invasive breast cancer, there were in the guideline concordant group 5.9%, whereas it was lower in the active monitoring group, 2%, with a difference of 1.7%. Looking at the one-sided analysis, they concluded that active monitoring is not inferior to guideline concordant care group. Continuing with this ITT analysis, as per the initial randomization, secondary endpoints were to look at the invasiveness and the characteristic of the invasiveness, and there were no difference. If we look at the size of the invasive, at the HER2 status, the nodal status, or the grade, there were no significant difference between GCC group and the active monitoring group. Looking at endocrine therapy, there was no difference neither. In the radiotherapy group, 26.6% in the GCC versus 7.4% in the active monitoring group. Looking at the surgery, the mastectomy rate was 5.5% in the GCC group, lower in the active monitoring group, 3.7%. Now, since many patients have switched arm during the analysis, so they did also a per protocol analysis. It means that patients who really did the treatment, and total of 673 who did not change the arm during the analysis. Again, in the GCC group, 8.7% of 2 years cumulative rate of invasive cancer, lower in the active monitoring group, which is 3% of cumulative rate invasive cancer, with a difference of 5.6%. Looking at the secondary endpoints, you can see again that radiotherapy was 48% in the GCC group, more than the active monitoring group, which was 3.5%, a significant difference. The same for mastectomy rate, which was 8.9% in the GCC versus only 1.9% in the active monitoring group. Now, if we look at the as-treated analysis, it means that any invasive happening, regardless of the way of randomization, you can see in the blue the GCC people who the patients who had surgery for invasive versus the orange, the active monitoring group, and there was no difference in the invasive size, in the nodal status, and in the grade of the disease. So, in conclusion, in this pre-specified primary analysis of the COMET study, the 2 years cumulative rate of invasive cancer was 5.9% for women randomized to guideline care and 4.2% for the active monitoring. There were no significant difference between groups in invasive tumor size, nodal status, or tumor grade. 31% of the participants did not adhere to their arm allocation. Most of them have favored the active monitoring after being randomized to the guideline concordant care. No obvious imbalance in patient characteristics between groups, but we cannot really exclude bias in the participation in this primary study. So as a conclusion, at 2 years, women with low-risk DCIS, so again, it's a low-risk DCIS, randomized to active monitoring had a non-inferior rate of invasive cancer in the ipsilateral breast compared to those randomized to guideline concordant care. Short-term results are encouraging, but we definitely need additional follow-up to determine the long-term feasibility of this approach and to be able to convince doctors and patients about this new era of changes. Now, I said doctors, I'm meaning everyone, including surgeon, radiotherapist, and everyone. So this is acknowledgement to the COMET study and to everyone for your attention today.
Thank you so much, Rita. Great talk. And yeah, I think the audience, the people are ready for it. Now we doctors. Doctors should be ready for it.
Like starting with us initially, now, patient coming with DCIS to confirm that we omit surgery. I personally feel it's going to be difficult, but definitely we need to follow the data, we need to follow the guidelines, we need to follow the recommendation, and convince each other and ourselves first.
Of course, there's one limitation that there was endocrine treatment allowed in both groups.
Correct.
In the Netherlands we have, and I also think in the UK, the LORDS and the LORIS study, that it's only active surveillance, but I might be wrong. So any questions from the audience?
Anybody else before I start? No, I think it's dangerous to draw conclusion based on these studies, a short follow-up. And remember, pathologist concordance always, you have to choose your low risk and not the higher risk.
And they mentioned 2 pathologists for every case that was included.
I'm just saying to take this to the practice, it's going to be dangerous when you don't have that controlled environment, as you mentioned. Because, I mean, from the one end, we're worried about any closed margin. If it is not 2-3 millimeter, my God, you have to do excision, to now saying observation, right? Yeah.
I totally agree.
Actually, I'm just thinking loudly. This study, they have to be commended for doing this study without doing the decision, tool, oncogenic tool, for example, to help them. They used clinical biomarkers. We use available to every one of us in their own clinical practice. So they have to be commended. And indeed, we have learned for a long time that not all DCISs are created alike. We know that we over-treat. We know we over-diagnose, especially with screening mammography. So I find it very encouraging, very promising. We cannot adopt it at the moment, but I think they have to be commended. Very smart trial, very realistic, considering the screening mammography these days.
I totally agree, and adding more biological factors in the analysis.
Absolutely. We see a lot of young patients now with this, with the MRI being done. You find the whole breast DCIS.
Correct.
What to do?
Correct.
This is a light at the end of the tunnel, finally.
Not the end of the tunnel, though. Not yet.
Okay, yes. So last but not least, I'd like to introduce my dear colleague, Dr. Mohammed Al-Bashir. He's a previous chief of the Tawam Breast Cancer Center. We are both Tawam survivors. So we're talking about Tawam survivorship. And he's going to talk about leaving the axilla untouched anyway. Dr. Bashir, the floor is yours.
Thank you, Ernest. Thank you. Let me just make sure I know how to use this. Good. So it looks like the trend at San Antonio this year was all about de-escalation. So this is also a de-escalation study. Thank you, Dr. Aida and the AUS for the kind invitation. Presenting this on behalf of Dr. Turalf. And this is his disclosures. The main disclosure related to this trial are in the bottom. And ENSEMA is actually one of 4 ongoing de-escalation trials evaluating complete omission of axillary surgery in patients with breast conservation surgery. And the result of the SOUND trial was presented last year, which showed that you can omit sentinel lymph node biopsy in patients with tumor size up to 2 centimeters. Already the ENSEMA published their secondary outcomes in 2020 on the pre-planned central quality assurance review process for postoperative RT planning and axillary contouring. And in 2022, they published their patient-reported outcomes with quality of life data results showing that patients with no sentinel, as you expect, benefited regarding arm symptoms and functioning. The goal of the ENSEMA study was to demonstrate that complete omission of sentinel lymph node biopsy does not result in inferior invasive disease survival compared to the standard group who had sentinel lymph node biopsy. So this is the design of the study. They recruited about initially 5,500 patients, and the plan was to randomize 1 to 4. 1 in the no sentinel lymph node biopsy group and 4 in the sentinel lymph node group, because they were planning a second randomization later for those who had a positive 1 to 3 sentinel lymph node, to randomize them to sentinel no further surgery or complete axillary dissection. Obviously, the point of this presentation is focused on the first randomization, which is no sentinel lymph node versus sentinel lymph node. And the study took place in Germany for the majority and some centers in Austria. The analysis of the primary endpoint was performed on the per protocol set due to the non-inferiority. So this is a phase 3 non-inferiority study. And based on the statistics, they were looking for a hazard ratio of 1.27 or less. And the multivariate Cox proportional hazards model was used to adjust hazard ratio for stratification factors such as age, clinical tumor size, and tumor grading. Again, it was 1 to 4 randomization, and for powering, the calculation was for 851 events and a total of 5,230 patients. Assuming 5% of patients who had to be excluded from the PP analysis, they came up with a number of 5,500 to be needed. The final efficacy analysis was planned, event-driven, when 851 events for the first randomization occurred. A time-driven analysis was pre-planned after a follow-up of 5.5 years of the last patient recruited. So this is the consort flow diagram. This is, again, 5,500 patients were recruited. The main reason why some patients were dropped out from the ITT group, the intention to treat, where some of them chose to undergo mastectomy and some withdrew consent. And then they ended up with 5,154 patients, but some were excluded again because 252 had no post-op RT and 38 axillary surgeon was not according to the randomization arm. So they ended up with a total number of 4,858, about again 38,096 randomized to the sentinel and 962 to the no sentinel. As you can see, the positive sentinel lymph node rate in this study was about 15%. 3.4 had micrometastasis and 11.3 macrometastasis 1 to 3, and only 0.2% had more than 4 or more lymph node positive. So the overall positive sentinel lymph node in this trial was 15%. Here is the patient's characteristics between the two groups were very similar. You can see the mean age was 62, although we recruited all ages, but the mean age was 62. And the majority of the tumor size, 90% was T1 on the clinical selection, but on the final pathologic tumor size, T1 was 79%. And 95% of the tumors were ER/PR positive, and HER2 positive was only 3%. This is the per protocol analysis. As you can see, the survival rate 5-year in the sentinel group was 91.7 versus 91.9, and the study proved that that omitting sentinel lymph node was non-inferior to sentinel lymph node biopsy, and the hazard ratio was well below the preset hazard ratio 1.271. This was also held true when they did the intention to treat analysis, and when you look at the endpoint events between the two groups, there was no difference. There was a slight difference in the axillary recurrence, 1% as you expect in the no sentinel lymph node group versus 0.3% in the sentinel lymph node group, but otherwise there was no difference in other events. And this is the overall survival, again, with no difference between the two groups. The survival overall, 98.2 in the non-sentinel versus 96.9. This is the forest plot between the two groups. As you can see, there was not much heterogeneity between the two groups. And it was interesting to see that tumor size more than 5 centimeters and invasive lobular had no disadvantage to doing sentinel lymph node biopsy. So in conclusion, the NCEMA enrolled trial study enrolled 5,500 patients and proved that omitting a sentinel lymph node biopsy in patients with early breast cancer who are scheduled to have breast conservation. One point I forgot to mention, they really mandate whole breast radiation in this study, and the high tangent or axillary radiation was not allowed. So it had to be just whole breast radiation with the breast conservation, and the patient had very good survival, and the de-escalation concept they recommended for patients age 50 and above with low or intermediate grade, not ER positive, HER2 negative subtype with a T1 tumor size. This is the acknowledgement for both centers in Germany and Austria, and the paper was actually published in the New England Journal of Medicine already December of last year. And thank you for the opportunity.
Thank you, Mohammed, for this great presentation. And as a surgical session, we gained a little bit of the time, but we went over time. So we have more time for questions, I guess. But what are we going to do?
That's
So
exactly my question.
This just allows you to, this is the whole point about MDT, is not to do the usual cases that you know the answer to individualize cases like this. So you have a small tumor, old lady, you can decide on to omit, a favorable tumor and so forth. But also, this study, I mean above 70, above 65, we already just talked also about omitting radiation like mirror and whether it's 65 or 70. But in this study, they mandate radiation therapy. So it's really, you have to put everything together. So they mandated radiation therapy. So you may decide, I want to do a sentinel. So if it's negative, I can omit radiation if she's 65 or 70, something like that. Or maybe the oncologist wants to know if the patient is candidate for CD4/6 or not. So you really have to individualize the treatment. I have to give something to the oncologist, in the presentation. You know what I mean? So you may want to know what you want.
Great job, great job,
Yeah.
great job.
Actually, this study, when I saw that study, indeed, it validates the practice and it validates the surgical studies in the field of breast cancer. I don't remember Z11 or Emirates, the one that showed you don't need to do further the outcome for patients with sentinel node biopsy,
Z11,
yeah. versus node negative, less than 2 centimeter, the outcome is the same. So indeed, in real life practice, when patients come to you, and I'm sure you see this, a patient is having some lump, she goes to a general surgeon, the surgeon removes the lump, and the lump turns to be cancer. Negative margin, axilla has not been touched. What do? Indeed, I have been practicing, if the tumor is less than 2 centimeters, I never went for resurgery. I only give radiation. I think INSEMA validates this practice. And some of my colleagues is like, no, we have to do resurgery, stage the axilla. But indeed, this is a great study to validate your Z11 data.
Yeah, I mean, this study makes you think before you do any step, is it going to change your management or not? So if there is not much of a change of management, you really have to think about it twice.
No, it makes sense. It's very excellent data to validate 10 years old practice that we haven't been following, especially for those lumpectomy patients done by.
But also for the radiation point, some centers in the US apply partial irradiation. So in this study also, they only did whole breast. And, you may want to know the axilla because in one disease is excluded from partial breast irradiation. So these are all the things that you really have to take into consideration.
I had a twist on the same thinking that this is an extreme Z11. So what we learned from Z11, that about 25% had residual lymph nodes, but it didn't impact the outcome. So here you are, even I'm sure there were some patients that were node positive.
Yes, 13%
right.
of the sentinel.
That's
so
what
you're
I'm saying.
expecting the
The same like
13%.
Z11, but it didn't impact the outcome.
The rate was lower here than Z11 because Z11 was 27%, but they did
Because
not
they
do
were
any
high risk.
ultrasound. They didn't do any axillary ultrasound. It was just a clinical examination. These patients in this trial had ultrasound, and those with suspicious lymph node underwent FNA or core needle and were negative before they were randomized.
But the size was
Here
smaller.
is my
here.
question
It was less
too.
than 2 centimeters.
For those patients, would you follow up with, like, let's say, would you follow up serial ultrasounds of the axilla?
I wouldn't.
It's part of the breast, the ultrasound is part of the breast anyway, so you will do it in
Surveillance.
routine.
We do mammogram. Annual mammogram.
I do mammogram and ultrasound on my breast cancer patients follow-up because I honestly, mammogram alone, at least our protocol from Tawam. I know Tawam now doesn't do a lot of ultrasound because of the time constraints, but they come to me to do the ultrasound.
Not Tawam anymore.
I tend to get away from this
For
ultrasound because
fairness
it
to
only
radiation, back to radiation, because when you are giving the standard radiation, you are in fact radiating level 1, right, Brahim? Level 1 is irradiated.
Yeah, but high tangent field and auxiliary radiation were not allowed in this trial. So it was really just whole breast radiation as much as possible. But some of the axilla is covered, but not aimed at the axilla.
Any more? If not, oh yeah, this one, yeah, sorry.
Thank you. I just have one comment. I'm echoing what everybody has been saying, not to mix and match trials and end up downstaging all treatment, including surgery and radiation to the axilla. So similar to what we've been discussing about the Supremo, I agree with omitting radiation in 1 to 3 positive lymph node who had axillary dissection. But when it comes to sentinel lymph node patient, we have to be very careful when we omit surgery and radiation, particularly that if you look at the Supremo, in fact, the way we think is that there aren't going to be a great, like the chances of having extra positive lymph node after the sentinel lymph node is low. But in fact, the main reason to treat the chest wall in these patients is to lower the risk of local recurrence. So these patients are at high risk of local recurrence as well. And in the Supremo itself, if you look at the radiation fields, they did not mandate regional radiation. So those patients who had positive lymph nodes had chest wall radiation, and they left the regional lymph node to the discretion of the centers they were treating. So it was mostly of a local treatment. And similarly, in the post-neoadjuvant setting, with omitting radiation after full axillary dissection is one thing, and omitting it with only 2 sentinel lymph nodes being being negative in the setting of neoadjuvant chemotherapy is a different scenario.
I think with all the de-escalation trials and the studies you have now, you really, you need to individualize the treatment to see what's applicable to your patient here and there. And it's really going to be a challenge to put all of these together, because sometimes you feel one contradict the other. But it's really, here is the trick, and that's what's going to help us to individualize the treatment to our patients.
Even after neoadjuvant therapy now, even if you have a small lymph node positive, it is not an automatic lymph node dissection. These are coming.
It's under investigation, but yeah, I think we're moving forward to that.
Yes. No, one thing I always tend to think about is this study was done in Germany, I think.
Germany and mostly Germany.
But, you know, the type of population they have, it's different. The biological, I mean, I think in our region, before we take this into consideration, I think this has to be, I mean, yeah, so it's a different...
Younger, maybe they're 10 years younger, but...
Well, they said the same thing about Z11, by the way, Dr. Aida. Z11, they said the same thing, and then many other places confirmed the same finding. One thing about the power here, by the way, they did not reach the number of events they had it planned, which is 800. They only reached 500, so the events was very low. And the same thing happened with Z11. When they powered the study, they wanted enough number to make it powerful, but they didn't get it. The axillary recurrence was low, and they had to, end up, and there was no statistical difference between the arms.
One thing is for sure, with de-escalation, we should bear in mind that any de-escalation should not compromise our oncologic safety. So we cannot run out of this room altogether. We have to do it in an orderly fashion, and maybe it's up to the surgeons to decide who goes first, but that's me saying as a surgeon. And maybe Dr. Ibrahim is the last one leaving, but anyway, we will leave there. And this session maybe also underscores the fact that less is probably more, and that is something food for the discussion in the MDT, that not one size fits all. But having said that, we should also be aware of the fact that if you ever are confronted with a case of, for instance, recurrence, where they did a de-escalation of the surgery, and you were asked as an expert to give your opinion, please allow also take it easy and don't go back to the classic ones, all right? Okay. If no questions anymore, I'd like to have the certificate of appreciation, and I'd like to give the last words to our respected organizer, Dr.
Just EOS are more important. Just one last update on anthracycline, not on this one. I gave a reference from last week, say goodbye to anthracycline in early breast cancer. So just Dr. Hamad, sorry to spoil your conclusion. This was from Hal Burstein and the READ trial, 10 years follow-up, that shows no significant advantage in the most cases, but in selected cases, yes. That was their conclusion, not mine.
I think we just entered the Dr. Hassan second Congress. So
Okay, so thank you so much. Actually, this was such a fruitful meeting. We learned a lot. We had fun, and I think thanks everyone for the support. This wouldn't have been successful without your presence, indeed. So I would like now to thank our sponsors who supported us for this event. So I would like to start with Lily. I'd like to thank Novartis. AstraZeneca. Menarini. Group photo for the survivors of today.
Musa, end of games.
I can just present.
You ruined your style.
3, 2, 1, go.
Survivors.
Thank you.